Good evening, everybody. On behalf of the MOGs, it's my proud privilege to welcome everybody here, the assembled distinguished faculty, as well as the audience, for this TOG webinar on alloimmunization, anticipate and act. For today's program, our academic partners are Bharat Serums and Vaccines, and of course, Science Integra, Subbu, Seshan, Sana, and Shrimon have been a backbone for all of the activities of Foxy as well as individual societies over the past 3 to 4 months since the lockdown has started through this Bridging Bharat initiative. So, warm welcome to everybody and to all the assembled dignitaries. Namaskar and greetings to you. Can we have the next slide, please? I don't think I need to introduce myself. Let's skip to the next slide. Do we have Dr. Archana Verma's introduction? Okay, since it's not there, I'll just introduce her. Okay, fine, it's coming. Dr. Archana Verma is a distinguished Foxian, and I would say she's a pillar in Foxy as far as all activities of the Public Awareness Committee go, because she was a past chairperson for the Foxy Public Awareness Committee. She has a special interest in infertility and creating awareness on women's health. She's an associate member of the RCOG. She has her own nursing home in Ghaziabad, of which society she's been the past president and the secretary, of course. Our paths first crossed, I would say, many years back when she was the organizing secretary for the North Zone Yuva Foxy, which was held in Noida. She has also been the organizing secretary for the UP ISAR and the midterm UPCOG. She's been a member of several public health organizations, including Lions and Rotary, where she has won awards and medals to her credit. She has also been appreciated in several different fora with different awards. I think the most distinguished of these have been the Women of the Year Health Award, and of course, a special appreciation from the CRPF, for which she has conducted public health and awareness camps throughout last year when Dr. Nandita Palshetkar was the president of Foxy. For this, she was widely appreciated and felicitated both by the president of Foxy and by the lay people, for which she has been showered with much love and blessings. I would request Dr. Archana Verma, who is the convener of today's program, to please introduce our distinguished guest for today, Dr. Nandita Palshetkar.
So, very good evening, everybody. As Dr. Nandita Madam has joined.
I can't see her, and in fact, when I called her, I think her phone was not being answered.
Phone was not available.
So as and when she joins in, we'll have her message. If you want to introduce her now, you can do that, or we can introduce her when Madam
I think I will just say introduce. When she joins, we will introduce at that time. We all know Dr. Nandita Palshetkar. She has done the wonderful. She has been a wonderful Foxy president, and who doesn't know her work? And still now she is doing a lot of new things and innovative things. And she did the that. We for Stri campaign, where she made every woman felt very safer, smarter, and whatnot. And we all did a lot many programs and got so many appreciations also. And she is the ART specialist all over India for last 20 years. And we really appreciate her, and it's honor for her that she accepted her today as a chief guest. And we'll be waiting and for the madam, and hope very soon she joins. So the next, I think we.
Sana, can we have the slide of introduction for Dr. Jaideep Tank, please? Yes, madam, please go ahead.
In today's program of RH Incompatibility with the Anticipate and Act, the guest of honor is all our favorite Dr. Jaideep Tank. We know Dr. Jaideep Tank as a really, first of all, it's honor to introduce him, and it's a great motivator of all time. And yesterday only we saw how the Foxy did the online voting credit. Main credit goes to Dr. Jaideep Tank for making it so much easily accessible to each and everyone. And he's really a very focused person, hardworking Foxian, and whose introduction I always say really need a standing ovation. And he's at present he's the Secretary General of Federation of Obs and Gynae Society, and immediate past president of Mumbai Obstetric and Gynae Society. He was the chair of he's chair of International Federation of Obs and Gynae, that is FIGO Committee for Safe Abortions, and Deputy Secretary Asia Oceania Federation of Obs and Gynae, AOFOG. He is the ex-chair Publication and Newsletter Committee of Asia Oceania Federation of Obstetrics and Gynecology, again AOFOG, and Reproductive Endocrinology and Infertility Committee. And MTP Committee, he was a chairperson from 2004 to 2009, and still today he did a lot of work for Foxy. When we also saw that there was some MTP amendment, we all know he only can explain it better. And as he was a vice president forum for enhancement of quality in healthcare, and consultant Ashwini Maternity and Surgical Hospital Center for Endoscopy and IVF. He is a co-founder of Health Esperanza Healthcare Private Limited, and program director and member of board of Preferred IVF, and visiting consultant for IVF center of around 15 IVF center, and he is managing almost 3,500 IVF pregnancy annually all across the 15 this thing. So, and we all know Dr. Jadeep Tang. Sir, please give your blessings for today's program.
Thank you very much, Dr. Archana Verma, for that really wonderful introduction. I don't think I have ever been introduced so nicely ever. Please make sure that I receive a link of this recording so that I can show it to my wife and make sure that she knows all the nice things which people are saying about me. Thank you. Really.
Sir, don't worry, we have seen.
Thank you very much. I think I must first begin by thanking the president and secretaries of all the societies who have come together for this program. From Bokaro, the president, Dr. Kaushik Das, and secretary, Dr. Anupriya. From Jamshedpur, Dr. Banita Madam. I think I just spoke to Banita Madam some time back. And Dr. Ruchika Sinha. From Ranchi, Dr. Maya Verma and Dr. Geetu Sinha. From Dhanbad, Dr. Kavita and Dr. Neetu Sahai. I must extend a very, very warm and special thanks to all the presidents and secretaries and all the managing committee members. I think, as Dr. Archana Verma pointed out, for the first time in the history of Foxy, the managing committee elections have seen a voting of 94.5%, which is really, really astounding. Given that just 2 years back, the average voting used to be around 35 to 40% in the managing committee. Last year it went to 80% e-voting, and this year it has really surpassed all expectations by crossing 94.5%. So thank you very much to all the presidents, all the secretaries, and all the candidates who must have phoned them up all the time and made sure that they voted in time. Of course, a very large thank you to Dr. Archana Verma. She is so enthusiastic, she's so effervescent. Every time I see her, I feel very good about myself. And it's really one of the reasons that because of people like her, we like to stay around in Foxy. So thank you very much, madam. And of course, the conveners, Dr. Sashibala Bhosle and Dr. Apurva Datta. I've known Apurva now since quite some time. You have a fantastic program over here. I wish you all the very best for your scientific deliberations. With wonderful speakers and chairpersons, Dr. Vatsala Dadwal, Dr. Vidya Pratapara, Dr. Mala Srivastav, President of AOGD, and then of course a wonderful panel led by Dr. Mandakini Pradhan and Dr. Pratibha Singh, Dr. Nivedita Datta. Dr. Nivedita is very active in Manyata, that's where I know her from. Dr. Indu Chauhan, Anshu, Dr. Neha and Dr. Shazia. So I hope you will have a wonderful time. But before I give the mic away, it's always very difficult for gynecologists to give the mic away. Once we get the mic, we don't really like to stop. But I realize that I have already probably exceeded the time that was allotted to me. I must say that it's a wonderful honor that I am a guest of honor, with Nandita, who was the president when I was Secretary General. And by a strange coincidence, she was also the president of Mumbai Society when I was the secretary of the Mumbai Society. And of course, Dr. Mandakini Meg, we used to call Dr. Mandakini Meg our agent in the government because she was the side of our members when she was in the government. And of course, Dr. Anita Singh, our vice president, madam has always been so nice and cooperative. It's a real honor to be here. Thank you very much. And I hope that it turns out to be a wonderful webinar. I'm sure it will be. Thank you again.
Thank you, Dr. Jaideep. Thank you for coming. We always like to listen from you something.
Thank you.
And Dr. Pratik?
Yes, ma'am. Sana, can I have the introduction for Dr. Mandakini Meg, please? If it's not there, then I'll go right ahead. It's my proud privilege to introduce Dr. Mandakini Meg, chairperson of ICOG, and we thank her for all her blessings throughout our careers. All of us who aspire to academics and to positions in ICOG, she has been a guiding light to so many of us, including myself. She is an international vice president of MWIA Central Asia, vice president of AMWI Central Council. Of course, she has been the past vice president of FOXI way back in 2012 and 13, a past president of IFUMB.
देखो साना, TV तो देखो.
Past Dean of the Indian College of Medical Ultrasound. She was also chairperson for the Imaging Science Committee of FOXI at a time when chairperson post used to run for 5 years. It was a different era. Now we get only 3 years because there are so many aspirants for the post. They actually reduce the duration for the post. She is also Deputy Director of Health Services, Government of Maharashtra, in charge of family welfare, PCPNDT, MTP, and so many different issues where she doesn't like to publicly talk about it, but I know she has helped hundreds, maybe thousands of common obstetricians and gynecologists who have been trapped sometimes because of simple clerical errors in forms. Their machines have been confiscated or their entire nursing homes have been sealed. Quietly, she works behind the scenes without anybody even knowing. And as you heard, Dr. Jaideep Tang says she is our agent in the government. She works for the betterment of all OBGYNs and she is really an exemplary figure. She is a true example of what a Foxian should be, working behind the scenes for the benefit of the common OBGYN who sometimes is helpless when they are in such difficult situations. I give to you Dr. Mandakini Meg, chairperson of ICOG. She has several distinguished awards and medals to her credit. But if I go on speaking, then she will not have any time to speak. So I'm going to hang up the microphone right now. Ma'am, you need to unmute yourself, please.
So, good evening, Pratik and everyone. First of all, I really want to thank you for inviting me to such a august gathering. And Archana, thanks from the bottom of my heart. I can see Jharkhand, society, AMOX, and other societies who are, coming together for this wonderful webinar. And cause I think integration, as Pratik has said, integration is it should be there for so many programs, and we should not waste our energy and time into separate program. That is what I am looking for in the ICOG. First of all, I want bring in greeting from the ICOG that I can see so many of my newly elected people here. Almost the governing council is here. Mala, Abha, so many. Vidya, everybody is there. I'm so happy that you people are really contributing in the academic activities. From the ICOG, I want to say that in ICOG we are taking this corona challenges into opportunities. And as Pratik has rightly mentioned that we are doing so many of the programs which were not there before, because looking at the corona, we have started the courses in reproductive medicine. I think you people are aware. Reproductive medicine, fetal medicine, then endoscopy, and for 3 months continuously we were running the courses. Now there is online exam. Also, I want to inform here who are attending that for FICOG for the first time, please go to the website of ICOG, open it, and you will find that ICOG form is online, which recently has been updated. So I will request those who are desirous of, getting this FICOG degree, please, fellowship, please, fill in the ICOG form. Also, very important that, we are coming up with a journal club on 9th of September. We are going to have Pratik, we are going to have inauguration. This is also for the first time in the ICOG history. All the professors here, Anita, Madam, Mala, Abha, everybody will be a convener for that program turn by turn, and it will be conducted every second and fourth Wednesday, and we are calling it a Wednesday Wisdom webinar of ICOG. So that is, and third most important thing which we are coming up is a ICOG app. Like MOGS has got that app, so that you get all the information on the fingertip. So that is also will be inaugurated in the month of September. These are the few of the activities I'm just giving you. But I think you should regularly see the, and we are coming up with the many courses also, ICOG certificate courses. So please look at the website of the ICOG for future programs. So I think with this small this thing, thank you Pratik. Anything in the government or any work, if you feel any member is wants to take any kind of help, I am there for you. As a ICOG chair, I am there always. But as a true Foxian, I am there to help you. Thank you very much for calling me. Thank you very much.
Thank you,
Thank you so
Mandakini
much.
madam. Thank you.
Can we have the introduction of the next guest of honor, Dr. Anita Singh, please? If we have the formal CV, otherwise I'll just introduce her extempore. All right, it
CV
doesn't
of
seem
Dr.
to be
Anita.
there.
CV of Dr. Anita.
Yes,
Yes.
it's my proud privilege to introduce Dr. Anita Singh. She is ex-professor at Patna Medical College. She is the past president of the Patna OBGYN Society, current vice president of FOXY for the East Zone, chairperson for the Endocrinology Committee of FOXY 2014 to 16, 3 years before I took over. I took over from her, in fact. She is a member of the Governing Council for several terms, chief consultant at JP Hospital in Patna, several publications and presentations, contributions to chapters, books. And I will say this for Dr. Anita Singh that she is a legendary figure in academic circles in Patna and Bihar, always widely in demand, and her lectures have halls which are full. I have seen her students, even after several years, come and actually touch her feet when she is noticed or seen in a conference when she is having breakfast. She is just sitting quietly by herself in a corner, and some or other student will crop up and greet her and touch her feet. It just shows how humble she is, how down to earth she is, and she is always an inspiring figure for all of us who are academicians. I present to you Dr. Anita Singh.
Thank you, Dr.
Uh,
Pratik, for such nice
and
touching words.
Dr. Anita did such a wonderful on 8th March, such a great program on cancer awareness program.
Thank you, Archana. So once again, good evening to all smart and safe Foxians that we are now. And I wish to pay my regards to Dr. Mandakini Meg Madam, who is there, and also to Dr. Jagdeep Tank and Dr. Nandita in absentia. She'll be joining anytime. And I wish to thank the organizers of this webinar, especially Dr. Archana Verma, Dr. Pratik Tambe, and all the office bearers of AMOGs and the societies like especially in Jharkhand, Dhanbad, Bokaro, and all other societies which have joined. And I can see a very senior member, Dr. Mala Srivastav, who is there. We keep often meeting in these webinars nowadays. So without wasting much time, I say my great good wishes for this success of this webinar. And this is going on from, I think this will be going into all the societies of our country. And this RH immunization, RH ISO immunization, although there is nothing new about it, but it's still in remote places, people are not very much aware of the latest developments that have come up. And those messages should go to each and every obstetricians so that no women now undergoes this problem of isoimmunization, and we do not lose anybody out of the RH, any baby out of the RH incompatibility. So this is a very good message that you people like Dr. Pratik, Dr. Archana, Dr. Niranjan, and so many of you who are part of all these webinars are propagating every day and making such large efforts to make it popular and reach to the people. With these thanks, I thank you very much for inviting me as a guest of honor, and also I wish a grand success to the program today. Thank you.
थैंक यू अनीता मैडम.
Thank you, ma'am,
मैडम
for
यू
this
आर सो
inspiring.
पॉपुलर. आप देखो ना, आप कितनी आपकी पॉपुलैरिटी थी, और अभी ईस्ट में इंजेक्शन हो रहा है तो यू आर अनअपोज्ड, so that was the most wonderful thing.
Can we have the introduction of the two conveners next, please? Dr. Shashibala Bhosle and Dr. Apurva Datta.
डॉक्टर आभा मैडम. अपूर्वा का लगा देंगे ना पहले.
Abha, please unmute yourself.
Okay, so thank you, Dr. Archana, first of all for inviting me to be a part of this webinar, and Dr. Pratik, who has always been very kind to me. He has been inviting me to his programs. Thank you so much. And it's my pleasure to introduce the two enthusiastic conveners of today. The first is Dr. Apurva Kumar Datta, a young, energetic Foxian. These days we are seeing him in the webinars quite often. He is the member of the organizing body Obstetrics and Gynecological Update of Uttarakhand 2013 Organizing Committee of Foxy's first International Congress on Why Mothers Die in Utero, I think, which was done by Dr. Dilip Kumar Datta. He is winner of Dr. Kamini Rao Yuva Orator 2020, Padma Bhushan Kamla Bhai Hospet Award, Traveling Fellowship Award 2017. He wrote a chapter on hysteroscopic myomectomy in Textbook of Hysteroscopy by Dr. B. Ramesh. He has total 6 papers published and 1 paper accepted for publication. He is also an editor-in-chief of newsletter of Foxy's Sexual Medicine Committee. He is the executive founder member of Jharkhand State Chapter of International Spina Bifida Foundation. A regional faculty and master trainer of TOG Sat Sat. I think we were together in that program. And he is national coordinator for Foxy's CME workshop for safe abortion and contraception cafe. Seeing his age, I think he has got a lot of achievements and many more is going to come. So welcome, Dr. Apurva. May I have the CV of the next coordinator, Dr. Shashi Bala? Dr. Shashi Bala's CV, can I have it? Yes. Dr. Shashi Bala Bhosle, she is secretary of OBGY Society of Gwalior. She has worked as OB-GYN specialist in public health and family welfare, and she is serving the health department for last 33 years. And I think she must have done quite a good work in the public sector. So welcome, Dr. Shashiwala Bhosle as convener for today. Over to the convener, Dr. Apurva.
Yes, ma'am. With the permission from Archana ma'am and Pratik ma'am, should we start our session?
पहले कुछ you
Yeah,
just
please,
say
sir.
few words about as a convener, because you have done, you have arranged, you have asked all the president and secretary to
Okay,
join.
thank you. First of all, thank you so much, Abha ma'am. She is basically also from Dhanbad, so she always appreciated me for everything. And Archana ma'am, it's all due to you. I am here. You are always believing on me. You give me the opportunity to conduct this and to convener, and you are always there to help me. रात को 10 बजे, 11 बजे, 12 बजे, मैम ये प्रॉब्लम है. हाँ, बोल अपूर. So इसीलिए I always tell him कि
तभी तो मैं मदर फिगर हूँ.
Mother figure for me. Thank you so much, Pratik sir. You are always inspiration for a youngsters like me. You are doing so good work. So literally मैं आपसे personally बहुत कम मिला हूँ, but Pratik sir, I always follow you in the Facebook, in the WhatsApp, and I always admire your work. We have guest of honor Anita ma'am, Mandakini Meg ma'am. He always is there to bless me. We have Jaideep sir के कार्यकाल में ही मुझे सारे awards मिले हैं, तो थैंक यू सर, जयदीप सर, फॉर गिविंग मी द अपॉर्चुनिटी. मंदाकिनी मैम ने इस बार मुझे IICOG में कहा था, अपूर्व वी आर डूइंग ग्रेट एंड प्लीज गिव my blessings is always you as a ICOG chairperson. Thank you so much. We have such a Mala Srivastav ma'am is there, Vidya ma'am is there, Abha ma'am is definitely there, Shali ma'am is there. Then we have Leela ma'am is there, and we have Mandakini Pradhan ma'am is there, and all the chairperson. Thank you so much to be part of this. Thank you so much.
You start.
To Pam ma'am, Shashiwala ma'am.
Yes. Apurva has introduced and Apurva has welcomed everyone so profusely. So I also want to just add a line. I'm so privileged to be here in the august company of all you seniors. And thanks to Archana ma'am, she had faith in me and she made me a convener of this. And I'm meeting so many new friends this year. And so I look forward to a most rewarding CME today. Thank you so much. Apurva, you carry on. You introduce madam.
We need to introduce Dr. Vidya Thobi next.
CV of
We
Dr.
have
Vidya
the
Thobi.
presentation slide, please, of Dr. Vidya Thobi. Dr. Shashibala ma'am, would you like to do the honors?
Shall I introduce?
Yes,
Yes,
ma'am, please
yes.
go ahead.
Dr. Vidya Thobi, she is professor and HOD of OB-GYN at Amin Medical College, Vijaypur. She is chairperson, Food and Drug Medico-Surgical Equipment Committee, FOXY 2018-20. She is national corresponding editor for Journal of Obstetric Gynecology. She's been organizing chairperson of SOGA 2016. She's treasurer of SOGA and she's EC member for KSC AGOI and academic council member, Women's University, Vijaypur, and Amin Journal of Medical Sciences editorial board, and she's UG PG examiner, paper setter, and PG guide teaching for almost 30 years. So welcome, ma'am, Dr. Vidya Thobi, ma'am. Please, let's share her screen now.
Thank you very much for those kind words. I welcome Dr. Archana Verma. I need not introduce her. She is chief convener of this program. So she will be talking on prevention of isoimmunization, RH isoimmunization. As all of us know that this RH negative women who deliver the RH positive babies or otherwise those who are exposed to RH positive red cells are at risk of developing anti-D antibodies. So implementation programs, as Dr. Anita Singh was telling, that implementation of programs for these antenatal and postnatal anti-D immunoglobulin prophylaxis.
Madam, can't see you.
Has led to significant reduction. Yes. Am I audible?
Yes, yes, yes.
Ma'am.
So, however, these isoimmunization with serious sequelae still occurs in some of the offsprings, especially in the low resource countries where these immunoglobulin is not widely available. And wherever appropriate monitoring and interventions are available, this hemolytic disease of fetus and newborn can be treated successfully in most of the cases. So let us hear from Dr. Archana Verma about the prevention of this RH isoimmunization. Over to Dr. Archana Verma.
Ma'am, just a minute before
Let me
we
share
start
the
the
screen.
session. Ma'am,
Yes.
Prateek sir, Sashiwala ma'am, can you please introduce Prateek sir? Though he doesn't need any.
okay, no
He
need.
doesn't need any introduction. Dr.
Though he
Pratik is
doesn't
also
need
a
any
co-chairperson for me,
but-
and yes.
Yeah, Sana, can you just please share the CV?
या एक मिनट हटाना. हाँ, अभी हमारे मेन चेयरपर्सन तो रह गए ना. कोऑर्डिनेटर, मेन चेयरपर्सन, एवरीथिंग. हाँ, यस.
जी. Sashiwala
Dr.
ma'am, can
Pratik को
you?
introduce.
Sashiwala ma'am, are you there?
Yes.
Okay, I'm. Prateek sir, though he doesn't need any introduction, he is an ART consultant in gynae endoscopic surgery. He is an international diploma in advanced laparoscopy surgery from France, trained in assisted reproductors in Brussels, Belgium, and clinical embryology and ICSI at London and Singapore. He is a chairperson among endocrine committee between 2020 to is governing council member of ICOG, executive committee member ISAR, managing committee member and patron Mumbai OBG Society. He is a chairperson for Foxy Endocrinal Committee 2017-19. He is a managing committee member of IAG, MSR and AMC between 2015 to 2018. He is mentor of Mumbai Obstetrician Society Youth Council 2014 and 18. He is recipient of more than 14 Mumbai Obstetrician Society Award and 7 Foxy Prizes and awards. He is editor of more than 10 books, 3 Foxy Focus, and have a lot of other research work. His contribution more than this actually screen is not.
That should be enough. That's okay. That's the cue that you should stop.
Yeah, 3 Foxy. Actually, sir, your CV is so long.
That's why I said no need to introduce me. Let's leave
compile
it
in one screen, sir. Actually.
Thank you, Apurva, for that kind introduction. I think without further ado,
point and
it's already half an hour and the first talk has not started. So this program will not end on time. Let us proceed with the first talk. Thank you. Thank you so much. Appreciate it.
Over to Archana, ma'am. Please, ma'am.
Thank you. So, really lot of thanks to everybody and my chief guest and guest of honors, all Dr. Jaideep Tank and Dr. Mandakini Madam and Dr. Anita Singh. With proper okay from you, I start my program, and thanks to all the president and secretaries. Actually, when we decided, we made the 2 parts of for the RH isoimmunization, and the first part I'll be covering, and the second part Dr. Vatsala Dadwal will be taking. So my topic is how to mitigate RH alloimmunization, because RH alloimmunization is really quite bothering for obstetrician and pediatrician. Am I audible?
Yeah.
Okay.
See, this nodules is okay.
Okay. So because nowadays there's so much of hard COVID times and post-election Foxy time, and also the poor outcome of all the RH negative persons. It causes so much of disappointments, but it reminds me of a lovely quote from Martin Luther King that we must accept finite disappointment, but never lose an infinite hope. So let me start quickly, because as Dr. Prateek has already said that 30 minutes left, and because my talk is more of a awareness, I won't be taking much of the time. So what is alloimmunization is actually there is a rhesus conflict.
Madam, if I may interrupt you, sorry to interrupt. You need to make your presentation full screen, ma'am.
Okay.
Your slides are not moving here.
Okay.
Maybe you need to stop the screen share, make it full screen and share again.
There is something problem in my इसमें आ नहीं रहा है इसको, तो पहले ना ऑफ कर दो, stop share कर दो, फिर दोबारा करेंगे.
If the console has your presentation, they can also present it from there and you can speak.
Or you can double click on that.
शुरू से कर दो.
Perfect, yeah.
आ गया? Okay.
Yeah, good. Thank you.
Let me see, it's moving. Okay. So this तो you have already listened that this code है ना, I need not speak it again. And so what is alloimmunization is there is a conflict between mother and the child, the fetus. The mother is actually Rh negative and the baby probably is Rh positive, and there is a production of antibodies in an individual in response to a foreign red cell antigen which are derived from another individual of same species. And incidence to talk about, we are lucky enough that 80% of the humans are Rh positive, and in India the incidence is not so much clear, but around it is 5% because mainly we don't even report sometimes. Really, we don't report how many patients we are seeing, and so the proper incidence is around figure is 5%. Otherwise, in other countries, it is even up to the 34%. We all know that there is a blood group system is there, and there is a 4 types of blood: A, B, ABO, and O. And right from our preliminary teaching, the blood group A contains the antigen on the RBC, and there's antibodies present are B, and the B has the B antigen, and the antibodies are A, and AB has A and B, and the antibodies are none, and so the AB positive is supposed to be the universal recipient, and O is a universal donor. And then there is a rhesus system, and this rhesus system is having this thing mainly CC, D, and E, this factors, and there is a lipoproteins on red cell membranes which makes them Rh positive, and absence of them makes the Rh negative. And this we see that Rh locus is located on the long arm of chromosomes. It is 1p36 to p34, and it contains RhD and RhCe genes, which are quite similar, resulting from the common genes ancestor, and each contains 10 exomes. And mostly blood types are actually determined by the red cell antigen that are different. Mainly AB, O, AB group, they are different by 1 or 2 amino acids, and this Rh blood group contains D antigen, which differ from CC and EE by almost 35 amino acids. That is why it is highly and potent immunogenic, and it creates lot of immune response whenever it enters the blood. And for the pathophysiology, this slide shows that whenever any Rh negative mother marries and her husband is Rh positive, then he can be either complete having 2 copies of RhD genes, that is called homozygous Rh positive, and he may be having a 1 copy of Rh positive. It is called heterozygous. So heterozygous actually will produce 2 kids like this, and who will be Rh positive, and 2 will be the Rh negative, and homozygous all will be the Rh positive. And this placenta actually, it acts as a barrier to fetal blood entering the maternal circulation. Placenta is in between, and there is this placental barrier between mother and fetus is actually the leakiest barrier, and is quite poor to block to many chemicals which are present. And there is every time there is a exchange of the many between the circulatory system of fetus and mother going on, and so there are chances of leakage quite often, and silent feto-maternal hemorrhages occurring. And in this Rh negative, even this small blood is quite enough to awake the immune system. And this feto-maternal hemorrhages in the antenatal period, the chances are around 10%, and postpartum it is 90%. And it is the amount of fetal blood is not necessarily very high. Even as small as 0.1 ml of the Rh cells, they can be can produce a good immune response. And so this antibody response, as we know, this initial maternal response to Rh sensitization is production of the low level of immunoglobulin IgM antibodies, and they are confined to the maternal circulation, which is being unable to cross the placental barrier as they are big molecules. And then the second, after the within 6 months or 6 weeks to 6 months, the next crop of the antibodies are formed, which are an IgG, and they can cross the placenta. And this is the reason they're the firstborn infants with Rh positive blood types are not affected. And there's then the sequence of events in utero is similar. This maternal IgG enters the fetal circulation, it leads to destruction of the fetal red cells, and then there's that process comes when there's all the things goes to the fetal spleen, and then the immature erythroblasts are produced, and the fetal cell destruction and production of the anemia and jaundice and hydrops fetalis happens. And this Rh sensitization risk actually depends on volume of the transplacental hemorrhage, and extent of the maternal immune response. This both are very important. Sometimes even there's a hemorrhage, but there is no response. And the risk and the severity of the sensitization response increases with each subsequent pregnancy. And so without prophylaxis means injectable anti-D or antibodies, this risk is around 16% after 2 deliveries, and with prophylaxis, the risk drops to around 0.1%. And this potentially sensitizing events are mainly so many in the first trimester or the second trimester or even the last trimester. Then there can be the abortions, any type of abortion, invasive procedure, especially chorionophilus sampling, amniocentesis, and if there is any abdominal or pelvic trauma, and antepartum hemorrhages, placenta previa and abruptio placentae, and intrauterine fetal demise, multiple gestation and manual removal of the placenta, it can also cause, and ectopic pregnancy and cesarean delivery also has a chance of the fetal-maternal hemorrhage. And for regarding the antenatal management, so the main objective of the antenatal management is, number one, prevention of the RH alloimmunization in the RH negative unsensitized women, यानी जिसको पहले कभी हुआ ही नहीं है. And the second is the early detection and treatment of the fetal anemia in the sensitized women. And sensitization is determined by the indirect Coombs test, otherwise called antibody titer. And see in the antibody titer, how we do it in the clinically. If the husband is RH positive, then you screen the female at 20, 24 and 28 week of pregnancy by this ICT. And this, if indirect Coombs test is negative and 28 weeks, no further testing or is required, and prophylaxis is given. Prophylaxis means injectable anti-D. If titer is 1:4, then consider sensitization. This is all quite rough and depends also. And if it is 1:8, then intervention is needed, and fetal medicine expert is better to take. Either you do the serial ultrasound sound is very good nowadays. So careful monitoring of the fetus is done. And 1:16, it needs invasive fetal monitoring by the fetal medicine expert. This is actually the first one is called primary prevention, and all these are the, even this intervention is secondary prevention, and tertiary is when you are taking care of the after delivery, the transfusions are less. This is a slide showing indirect Coombs test. Actually here this serum is taken, the donor serum is taken, and the patient serum is taken, and the donor blood is mixed, and because there is antibiotics, so the agglutination cell is quite clearly seen. So the primary prevention is of two types. This, when we give in the antenatal period the injection anti-D, the one is routine this anti-D prophylaxis, antenatal anti-D prophylaxis, the AADPs, antenatal anti-D prophylaxis. And the second is a prophylactic antenatal. There's a difference in the prophylactic means whenever you are suspecting sensitization, and the other is a routine. आप दोगे every 28 weeks, because it is prepared from human plasma. So better to, it is always good to take consent. And if the patient refuses, please document it in your OPD. And the sensitized woman need no injection. And this, if you are simultaneously giving live vaccines, you can better avoid. And if less than 12 weeks, the dose is 50 to 100 microgram. And sometimes if it is not available 50 to 100, then and in what condition, like ectopic, mole, and that and this and that, we will be discussing in the panel also. Please keep on, because this is, I am not taking in much detail, but all the sensitization I have already said that whatever is in the first trimester, we should give around 50 to 100 microgram, and overdosing is not bad, so we can give 150, because some you may not get 50 wala injection. And the second and the third trimester 30 microgram, and additional 10 microgram for each 0.5 ml of the expected suspected fetal-maternal hemorrhage. It covers around 15 ml of the RBC in the blood or 30 ml of the total blood. And then the risk of immunization is, if no NTD is given, it is 12 to 13 overall. And in postnatal NTD, if you are giving only postnatal NTD injection, then it is still it is around 1 to 2%. And if you are giving antenatal plus postnatal both, then the risk is around 0.2%. And so the best clinical practice is to give both the antenatal and the postnatal prophylaxis. A word about the NTD injection. The two types of preparation are there, polyclonal and monoclonal. So I'll tell about the polyclonal only, because it covers all the 30 epitopes of the Rh antigen. Nowadays we are using this only, and it is being used since 1968, and it depends on the plasma donor and approved by use by all, and it has less of the reactions also. And the polyclonal anti-D for Rh prophylaxis is now universally accepted, and it's in all the guidelines like RCOG, ACOG, NICE, and MRC, and all the others also. And the route of administration for the NTD preferably is a deltoid muscle, because it deep intramuscular, it is appropriate and safe site to maximize absorption. And sometimes in the gluteal region, it is said that there may be less absorption, so not preferred there. And the word about the postpartum prevention. This anti-D immunoglobulins, they must be given as soon as possible, at least within 72 hours. And if not, just imagine if the 72 hours have gone, so don't be under distress, because at least some help can be there. So best is to give within 72 hours. But if not given in 72 hours, up to 10 days after the event, you can give. And according to some author, prophylaxis can still be attempted even at the delay of as much as 28 days after the sensitizing event, because it may be at that time the immune response is not so much. And so the conclusion is for the RHD negative pregnant woman, and when you determine the husband's RHD status, if it is D positive, then do the ICT of the mother, and if it is negative on the first visit, then repeat every 4 weekly. And if it is still the negative and at the 28 weeks, then give the NTD, and then can wait delivery at term. Never let any RH negative patient to go post term. And I really want to say that our patients should not feel depressed of when they are diagnosed RH negative by the doctor. And this is there should be a positive swag. Just when you never know before delivery or engagement what is the blood group of your fiancé. So if you are well aware and your doctor has given you about prophylaxis, तो एक ही बात आप कह सकते हो, कोई डाउट मत रखना, I can manage negativity, don't worry. And the doctor and the gynecologist should very be happily giving good family and happy family to all the RH negative mother, with less of post delivery injection and losses, pregnancy losses, and all. And the last my quote is, in the middle of difficulty lies the opportunity. So whatever the condition is, we have to carry on, and we must not be depressed or think. And so thank you very much. And so, dear chairpersons, I think
Dr. Archana, that was really a very nice deliberation, and we have actually look after our RH negative mothers and give them confidence that nothing will go wrong with you. We are here to look after you.
Yeah.
Yeah. We have to give confidence to all our RH negative mothers that there is nothing to worry. We can look after them very well throughout the pregnancy, after delivery, and we can assure that they will have a smooth sailing during the entire antenatal period. We'll have
if we are aware and make the patient aware and good counseling, because all of a sudden patient comes and said कि हमको तो ये बताया ही नहीं, बच्चे को blood transfusion हो गया, अब ये होगा. Too much of counseling is also bad. So my next speaker will take all the good and management of this pregnancy when there is a sensitized pregnancy. So over to
Yes,
you.
yes. It was an excellent talk, Archana ji. And I just have one question. Should the prophylaxis be repeated after 40 weeks? If you are giving at the 28 weeks, first means there are few
Actually,
people.
Dr. Vidya, nowadays, actually, it is said if there is hardly any difference, because after soon after the delivery, you can give, because one dose is quite enough, and previously there
Enough.
were 2 doses were being given, so now one dose is
Yes.
enough, and
Enough.
postnatal prophylaxis and postnatal testing and the condition of the baby is.
Yes. Thank you very much. Thank you. Let us move to the next talk.
Next speaker of the day.
Thank
It's
you,
a
Dr.
privilege.
Archana Verma, and thank you for inviting Dr. Vidya Tobi and myself to chair this session. I would
Yes.
request the
Thank you,
conveners to
Chairperson.
please introduce Dr. Abharani Sinha and Dr. Vaishali Chavan for the chairpersons for the next session, please.
Yes. Dr. Apur,
हाँ जी मैम should I?
yes, yeah, I'll introduce. Dr. Abha Rani Sinha. She's Professor OB-GYN SKMC Muzaffarpur. She's ICOG Governing Council member since 2021-2022. She's President Patna OB-GYN Society from 2017-18. She was Chairperson Quiz Committee Foxy 2015-17. She's been an executive member National ISOPAB, and she's a teaching experience of more than 25 years. She has publications in national and international journals, contributed chapters in Foxy publications. She is a joint organizing secretary AICOG 2014, and she has special interest, high risk pregnancy. So that's make her a very high profile doctor. Welcome, Dr. Abharani Sinha.
Thank you, Dr. Shashibala. Thank you.
Next slide, please. Dr. Apurva, you can introduce Dr.
Apurva,
Vaishali
you
Chavan, please.
introduce.
Yes, ma'am. Vaishali ma'am, hello ma'am, welcome in this webinar. Ma'am is Director, Obs and Gynae Department, Sayadri Super Specialty Hospital and Hadaspar Kamal Hospital at Pune. She is a postgraduate teacher. She is Chairperson Perinatology Committee, Foxy 2018-20. She is Executive Vice President, Pune Obs and Gynae Society 2019-20. She is a lot of publications in national international journal. She received many awards like Punya Bhushan Award, Samaj Bhushan Award, Vidya Gaurav Purashkar, Lokmanya Tilak Award 2017. So welcome ma'am, and hand over to chairperson to introduce our next speaker. Chairperson.
Dr. Vaishali, can you go ahead with the introduction of Dr. Vatsala Dadwal?
Hello.
Yes, Vaishali.
Yeah. Good evening, everyone. Thank you, Dr. Apurva, for this very kind introduction. And thank you, Dr. Archana Verma, for this invitation to be here today among this August gathering. And greetings to all of you. It's indeed a privilege to be here, a joint webinar, AMOGS, and Jharkhand OBGY, 4 societies of Jharkhand OBGY Society. Thank you very much for this honor. And I would like to invite the speaker for the next talk, Dr. Vatsala Dadwal. And before I invite her, I would just like to say that it was a wonderful talk, Archana Verma ma'am. You have covered all the points. And I always like to say we've been conducting a lot of RH negative webinars all over the country as part of Perinatology Committee programs. And the management of RH negative pregnancy is a team effort. It's a multidisciplinary approach, and it is very important to have an expert fetal medicine expert person with you when you manage these patients, because with the advance in the molecular science, and today we can actually find out the fetal blood cell by cell free fetal DNA, and with the advance in the Dopplers and ultrasound, with MCA, PSV, if it's more than 1.5 mom, and all these advances, we can, it is actually the most significant of the developments by which we can do surveillance for these Rh negative isoimmunized patients. So it is indeed an honor for me to welcome our next speaker, who is an expert obstetric. Can I have the previous CV, please? Yeah, who's an expert fetal medicine at fetal medicine, and she's Dr. Vatsala Dadwal. She's di- director of fetal medicine department of OBGYN at AIMS, New Delhi, and she's she's well known for her work in high risk pregnancy. She has more than 130 international and national publications with more than 50 presentations, and she is also nodal officer for PPT CT program. She's executive committee member fetal medicine 2014-15, and she's chairperson AOGD fetal medicine subcommittee to 2017 and 19. So welcome, Dr. Vatsala. Please go ahead.
Thank you, Dr. Vaishali, for your kind words. And I would like to thank Dr. Archana and Dr. Pratik for inviting me for this webinar. And it is a topic which is close to my heart because we do a lot of intrauterine transfusions. We see these patients pretty often. And also because it's also like the Jharkhand society is here, and I have done my schooling in Jharkhand. So I've spent my childhood in Jharkhand. So can I share my slides, please? I'm not able to see it.
You're also not able to see your screen. Yeah, now it's seen.
No, I'm not able to. Just 1 minute.
Yeah, it's visible.
So after Dr. Archana has told us that prevention is always better and use of anti-D is very important for preventing Rh isoimmunization, I'll talk about the treatment. Although prevention is better, the cure is also important, and intrauterine transfusion is one of the most successful fetal interventions that we know of. So I'll talk about the management of alloimmunized pregnancy and how we do the intrauterine transfusions and the outcome of these babies. But the most important thing is once the woman is isoimmunized and you find that the IC titers are positive, please refer to a fetal medicine specialist for further management. So alloimmunization can occur if we don't give anti-D, or we have given an inadequate dose, or we have missed the prophylactic antenatal dose, because that is also important in preventing isoimmunization, because fetal-maternal hemorrhage occurs antepartum also. If you have unrecognized fetal-maternal hemorrhage during antepartum period, or it could be sensitization to some other minor blood groups. Or if you haven't given a prophylaxis and it still fails, it may be because the dose was not adequate and you were late in giving the anti-D, or the patient may already be isoimmunized, but the antibody titers were too low for lab recognition, or you have given a defective immune globulin. So this is the data from AIMS, which Dr. Deka and all had presented. In 200 patients, the most important cause of alloimmunization was failure to give anti-D after delivery or after MTP, and also like if inadequate dose was given. So it is very important that we give the prophylactic dose antepartum and postpartum. So how do we manage the first alloimmunized pregnancy? So in the first affected pregnancy, the anti-D titer or the ICT is usually low, and the risk of severe fetal anemia is very less. And even if it develops, it is late in pregnancy compared to subsequent affected pregnancies. So we do ICT every month, every 4 weeks till 28 weeks, and then every 2 weeks. Or if we find a rising titers, then we do them every 2 weeks till we reach a critical titer. So what is a critical titer? It is a titer associated with the risk of development of severe anemia and hydrops at a specific institution. For our institute, we take 1 in 16 or more as the critical titer. So once you have a critical titer, there is no point doing ICT again and again. We straight away switch to Doppler of middle cerebral artery to monitor fetal anemia. So how do these women fare? In a series of 106 pregnancies, it was found that 60% of the women did not develop critical titers. Of the 40% who developed critical titers, only 26% had severe disease, that is, they required intrauterine transfusion or developed hydrops. It is very rare to see hydrops or severe anemia developing in first isomionized pregnancies, but we have an intrauterine transfusion for such pregnancies also. So just a summary of management of isomionized pregnancy. So first we have to see the critical titer, whether it is beyond critical or not, the ICT, or is the previous history of affected pregnancy. If there is critical titer is not reached or there is no history of affected pregnancy, then we monitor with ICT till it reaches critical titer. If it never reaches critical titer in pregnancy, we plan for an elective delivery at 37 to 38 weeks. That is to minimize further risk of fetal-maternal hemorrhage and sensitization. Anytime the critical titer is reached or woman is already has a previously affected pregnancy, then we monitor for fetal anemia, and if the baby is anemic, we give transfusion. Like Dr. Vaishali was saying, yes, a lot of development has been made. We could look at the paternal zygosity in these cases, because if the father is homozygous, all the babies are likely to be affected. But if the father is heterozygous, half the fetuses would not be affected. And then we can do, if the father is heterozygous, we can do fetal, isolate the fetal DNA in maternal circulation and then look for the D antigen, because that can also streamline those fetuses who are Rh negative when you don't have to do such intensive monitoring. But as of now, these advanced techniques are not available for routine use. So if a woman has a previously affected pregnancy, then what is important? It is important to take the history to know the severity of affection in the previous baby, whether it was just neonatal jaundice, what was anemic, what baby required exchange transfusion, was the baby hydropic, is there history of intrauterine transfusion in pregnancy, previous pregnancy, was there an IUD, early neonatal death, and we would know that the critical titers were high. This is important because the affection is more severe and occurs earlier in subsequent pregnancies. So the history is very important. So this is what we often see, a woman coming like this, a multigravida, 6th, 7th, 8th pregnancies with no living issue or only one living issue with multiple affected pregnancies. And it is nothing less than a miracle to give such a woman a healthy baby to take home. So how do we diagnose fetal anemia in women who have critical titers of ICT? The gold standard now is for non-invasive ultrasound monitoring of the middle cerebral artery peak systolic velocity, because it does not entail any risk of fetal loss and it does not exacerbate hemolysis. The invasive procedures, amniocentesis and chordocentesis, are totally out now. Amniocentesis earlier was done, we would take amniotic fluid and do spectrophotometry to see if there was bilirubin, then there would be a deviation at 450 nanometer. And this delta value was plotted on Lily's chart, and if it was in zone 2 high or zone 3, the baby was supposedly affected, and we would go ahead and do chordocentesis to confirm anemia by doing fetal blood hemoglobin and plan for transfusion at the same sitting. But this is not a good test because it is an indirect estimate of fetal anemia. It is looking at hemolysis and not hemoglobin levels. And also it increases the risk of sensitization, and there are a lot of false positives that you end up doing a lot of chordocentesis for babies that are not actually anemic. Similarly, ultrasound features are there. There's a whole list of features which can occur in Rh isoimmunized babies, but no parameter is sensitive enough to be an independent marker for fetal anemia. And in the absence of hydrops, no ultrasound finding can distinguish mild from severe disease. So when we do ultrasound for middle cerebral artery, we also look at ultrasound features of severe anemia in the baby. But if these features are absent, we don't give much importance to that. So the most important is doing middle cerebral artery peak systolic velocity. Important is to follow the correct technique and see that the baby is quiet and their angle of incidation is close to 0, so that you get very nice waves like this, and the peak systolic velocity is measured. And why is middle cerebral artery used for looking for fetal anemia? Because in response to fetal anemia, there is increase in blood flow velocity and there is decrease in blood viscosity. So there is increase in flow in the vessels. So the peak systolic velocity increases, and of all the vessels studied, middle cerebral artery has been most promising and reproducible. So if we use middle cerebral artery instead of amniocentesis for detecting fetal anemia, we can avoid 70% invasive procedures which are not required. So MCA-PSV in the earlier studies had shown a 100% detection rate with only 12% false positive, but a recent meta-analysis showed that it can pick up 86% of cases of fetal anemia. Some may be missed, but again, still it is much better than amniocentesis. So when we do MCA-PSV, we also look at features of fetal anemia on ultrasound to complement it. So when we have the values of peak systolic velocity, they're converted into, like we look at the multiple of medians. So for every gestation, there is multiple of median. If it is 1.5 or more, then it is moderate or severe anemia, and it calls for doing a chorosynthesis and planning for transfusion. If you look at the value of 1.5 moms, it is twice the value of the period of gestation. So even if you don't have the table right in front of you, if you have a fetus who is at 24 weeks, a 48 MOM means there is moderate to severe anemia. Similarly, how do we define anemia? Simplest definition is a hematocrit less than 30%, or we can express the hemoglobin values as multiple of medians, and if it is 0.64 or less, then it is anemic, or we can see the hemoglobin deviation from the normal. So if the hemoglobin is 7 grams less than what it should be for that period of gestation, it is severe anemia. So when should we start doing the MCA-PSV? We start doing MCA-PSV when critical titer is reached and there is a history of previous affected pregnancy. We can start doing as early as 18 to 20 weeks. It is no point doing earlier than that because we cannot do any fetal intervention. So the earliest intrauterine transfusions we have done is around 20 weeks for intravascular, and it can be used up to 35 weeks for monitoring fetal anemia. We repeat it every 4 to 14 days depending on the previous history and the trend of the PSV as we monitor these fetuses. So just a flowchart showing how we use this MCA-PSV. If it is more than 1.5 and the gestational age is less than 35, that means there is moderate to severe anemia. We do chorosynthesis to confirm anemia, and if the baby is anemic, give IUT at the same time. If it is less than 1.5, then we monitor. If the gestational age is more than 35, but the MCA-PSV trend shows a normal trend, then we can follow with MCA-PSV and induce labor at term. If the trend increases, then we may have to resort to delivery. If the gestation is more than 35 weeks and we find that the MCA-PSV is raised, then we would prefer to deliver rather than do the procedure. So the indications for doing intrauterine transfusions are, if you find a baby with high drops, we still see almost all 10 to 15% of the cases we get come with hydropic fetuses, sometimes severe high drops, or when we find there is fetal anemia because of high MCA-PSV, and we do a chorosynthesis and we find the hematocrit is less than 30%, we proceed with transfusion. So the earliest transfusion you can do is at around 18 weeks. With very early gestations, intraperitoneal transfusions can be done because below 20 weeks, intravascular becomes very difficult. And so we do a direct vascular access. So it is definitely better to do a vascular transfusion compared to intraperitoneal. The outcomes are better, and we prefer the umbilical cord. So where should we target? So we usually target the umbilical vein because if you puncture the artery, the risk of fetal bradycardia is high because of spasm. The vessel goes into spasm. So we sort of localize the umbilical vein at the cord insertion because that is the most stable part, and then that is where we enter with the needle to take a sample and then decide for transfusion. We do not use the umbilical cord insertion near the fetal end because of vagal innervation, and if you puncture, there is a risk of bradycardia. Free floating segments of umbilical cord sometimes we use for transfusion if you're not able to access the placental end of the cord, but then they're very difficult to access because the cord is very slippery, and to get your needle into the cord becomes very difficult, and you may have to do a number of attempts. The other site is intrahepatic portion of the umbilical vein. This is also good site to do because the risk of fetal distress is low because there is no inadherent puncture of artery. There is no artery there. So some people also prefer intrahepatic, but for that, the fetal abdomen should be anterior for you to access the vessel.
Yeah.
So what is the aim? The aim is to raise hematocrit to about 45 to 50%. We do not raise it to supraphysiological levels like 55, 60 because polycythemia is also harmful. And in very severely and hydropic fetuses, we gradually normalize and raise the hematocrit to 45 to 50 over 2 to 3 transfusions to avoid overload. And how do we estimate how much blood has to be given? So there is a formula which takes into account the hematocrit you want to achieve, the fetal hematocrit, the donor hematocrit, and the fetal placental volume. Or there is a very simple table here in which, depending on how much you want to raise the hematocrit by, you have a coefficient which you multiply the estimated fetal weight to give you the volume in ml. So the prerequisite for doing a chordsynthesis and IUT, which we usually do at the same sitting, is that it has to be evidence that there is fetal anemia, because it is an invasive procedure. We have to take consent, explain the risk of the procedure, including fetal loss, the risk for lining up in a cesarean if the baby is viable. We should have a good ultrasound, an expert team, and then we should do an ultrasound to see where are we going to target the umbilical vein. And there should be a facility for doing a hemoglobin immediately in the theater, and the blood should be ready, and we give steroid cover to all the fetuses who are beyond 26 to 28 weeks, which are viable, and we do the procedures very close to the OT so that if there is a distress, we can deliver them immediately, and the nursery is also informed before the procedure. So first important thing is to localize your placenta, see the path of your needle, how you're going to do the procedure, and we usually paralyze the fetus before the procedures, because if the fetus moves unexpectedly, then the needle may get dislodged and you may damage the cord. And once you're inside the vessel, then we actually take a little bit of the sample and do the hemoglobin by HemoQ immediately in the OT and start the transfusion. And we use O negative, and once we get the hemoglobin value, we do the recalculation as to how much blood has to be transfused. So we use O negative packed cells, and they are very packed, like 75 to 80%, so that we transfuse very little blood. The advantage of doing a vascular transfusion is that you can give it faster, 5 to 10 ml per minute, and we usually use irradiated and leukodepleted cells which have been screened for infections. So this is a video just showing how we prepare. So we use a 20 gauge spinal needle to use the transfusion. If the patient is obese, then we use Sheba needle, or if the placenta is posterior, we take pancuronium, and then we load the blood. So this is O negative irradiated blood, and then we clean and rape the patient and prepare the probe so that we do the procedure under proper asepsis. Then what we do is we inject pancuronium or vecuronium or atracurium into the fetal thigh to paralyze the baby, or if we are accessing the cord directly, like in an anterior placenta, we can give it directly into the cord. After that, important thing is to localize the cord insertion, for which you can use Doppler. This is an anterior placenta with a cord, marginal cord. So the needle you can see is coming through the abdominal wall, through the uterine wall, the placenta, and then you go into the cord. As soon as we enter the cord, we take 1 or 2 ml of blood and send it for blood group, hematocrit, and start the transfusion. We get the report within a few seconds, and then depending on that, we would sort of recalculate the amount to be given. So this is how we transfuse. So we have a 3D connector, and we use loaded blood in 10 to 20 ml syringes to push. So here you can see the turbulence because there is blood flowing in the cord. And after the procedure, we take some amount of blood and send it for post-transfusion hematocrit, because then depending on the post-transfusion hematocrit, we would decide about the next transfusion. Similarly, this is a posterior placenta, but the cord insertion is easily accessible, so we can puncture and use that for transfusion. And again, free loops are difficult, but we do sometimes. And the other, what we do if like the excess of insertion site is difficult, is intrahepatic. So this is a fetus which already has hydrops. You can see a lot of fluid here, and that is the needle entering through the uterus into the fetal abdomen, through the liver into the intrahepatic portion of the umbilical vein. Again, here we take a sample and then start transfusing. You can see the turbulence here. So after transfusion, we have to monitor these babies. One is to monitor the fetal well-being by kick count, biophysical profile and growth. Other is to monitor for anemia and to plan for the subsequent transfusion. So we'll just see how we plan for that. And generally we plan for the last transfusion around 33, 34 weeks, so that we can take the pregnancy to term and deliver 3 to 4 weeks after the last transfusion. And if sometimes when if we think that the technique is going to be very difficult, we may deliver them preterm also. And if the baby is not really severely anemic and we are sure that the hematocrit is within normal, a normal delivery can also be allowed, and it's not necessary that they have to have a cesarean section. So for subsequent transfusion, we rely on the rate of fall of hematocrit. So we have a value.
time का भी issue रखिएगा.
Just almost finishing.
Okay.
So it's not like MCA PSP more than 1.5 is not very good for timing second, third transfusion. So we rely on the rate of fall of hematocrit. So this is our own data. And the last transfusion we usually do around 34 to 35 weeks. What is the outcome? The outcome are pretty good. For our own data, we have done more than 1,000 transfusions till now, and we have a survival rate of 90% for hydropic and almost 94% for non-hydropic babies. And it's been seen over the years that the outcome has become better because of expertise, better ultrasound machines, because we use paralysis for the baby. And what are the complications? It may be PROM, cord hematoma, bradycardia during procedure leading to emergency section, even fetal deaths and neonatal deaths. And so procedure-related complications, for every complication you do, there is a risk of 1.6% fetal loss. And our data is also the same, and we have also published our paper. Then what is the neonatal outcome? These babies may have hyperbil at birth requiring partial or exchange transfusion, or anemia requiring exchange transfusion. And some of them also require top-up transfusion after delivery because of suppression of their own bone marrow. So they have anemia. And it has been shown that especially the hydropic babies may have some neurodevelopmental delay on follow-up. So how do we manage early onset severe anemia? Because we see patients 7th, 8th gravida with multiple losses, with previous baby affected as early as 20, 22 weeks. So what do we do? Then we give IVIG. So we start IVIG around 12 to 14 weeks. And it has been shown in the PETIT study also that giving IVIG actually delays the development of severe anemia. So the baby is a little bigger and transfusion becomes easy. So we have also done a study in which we're transfusing IVIG with blood during transfusion, and we found that the rate of hematocrit was lower. So the other options in very dire situations when you have repeated losses and babies getting affected very early is to use a gestational carrier who is not alloimmunized, or you can use donor sperm from Rh negative father. So to conclude, Rh isoimmunization is preventable, and anti-D is available with us, and treatment of fetal anemia with intrauterine transfusion is feasible and is very successful. But again, timely referral is very important because subsequent pregnancies are more severely affected and needs to be monitored in a referral center. Thank you very much.
Thank you, Dr. Vatsala. It was an excellent talk, and it was a visual treat to our eyes to see the technical part of the presentation. It was really wonderful. And the one message as a chairperson I would like to say that anybody who gets a sensitized pregnancy, that should be referred to a fetal medicine specialist, because earlier the anemia is recognized, fetal anemia is recognized, earlier it is managed, we get a better prognosis. Because once it reaches to the severe hydrop stage, I think we may land up with neurodevelopmental complications. So earlier to recognize and earlier to treat, that is the key in success of these pregnancies. And you are doing a wonderful job as a fetal medicine as a specialist. I've also studied from a school in Jharkhand, so I think we share the same feelings, and it was nice to know. And the other thing, I was also very impressed by your talk in AICOG. I still remember your talk in CME on amenorrhea, and I really congratulate you for that also. And it was a wonderful talk, Dr. Vatsala. I enjoyed every bit of it. One question, is there any role of combined intrauterine and intraperitoneal transfusion in order to delay the next intrauterine transfusion? Is there any study or is there anything like that? Dr. Vatsala? Hello?
I think there are some network issues, ma'am.
Yeah, and she is not visible also.
No, she is visible to me, but perhaps she is not able to hear me. Okay.
I think it's frozen, yeah.
Yeah, she is frozen. Okay, so thank you once again, Dr. Archana and Dr. Pratik.
And Madam, best thing was all the studies were heard and Dr. did.
Yeah.
All her presentation.
Yes, this shows the dedication of her work, and it's really appreciable.
Her video was excellent, the way she showed herself the procedure.
Dr. Vatsala, are you on? Can you hear us, Dr. Vatsala? Please unmute yourself.
I think she must be very
Sorry,
busy.
no, I lost the connection, so I just connected.
Only one thing, I only wanted to ask you one thing. Is there any role of combined intrauterine and intraperitoneal transfusion if we want to delay the next IUT?
You could do, but we are not doing intraperitoneal.
You are not doing it.
Intraperitoneal has a role when it is very early.
A very early gestation. Yeah.
Yes.
And is there any role of plasmapheresis and along with IV immunoglobulins to the mother to delay the, like in very early transfusions, to delay the early transfusions?
It is written in literature, but we don't have any experience. But we have experience with IVIG and it works.
Thank you so much, Dr. Vatsala. It was wonderful.
Yeah, Dr. Vatsala,
Thank you.
You
Thank
did
you
the
so
wonderful
much.
thing. I'm so happy that whenever I think of RH negative, I always think of Dr. Vatsala and other also, and Dr. Mandakini Pradhan. Next, so
we had one patient in Gangaram Hospital who was isomalized at 16 weeks. So to that patient, we had given IVIG, and then this patient could pass off the time, and she be delivered at around 30 weeks, and she had a successful pregnancy outcome. Now the baby is almost 12 years old. So we had used IVIG in few occasions.
Thank you, Dr. Archana, Dr. Pratik, and over to the conveners for the next session.
Thank you, Dr. Archana, Dr. Pratik. Thank you.
Thank you, respected chairpersons. I would request our convener for today, Dr. Shashibala Bhosle, to introduce the next set of chairpersons, respected Dr. Leela Vyas and Dr. Mala Srivastava.
Sure, thank you, sir. Yes. Now, first of all, I would like to introduce Dr. Leela. Yeah, Dr. Leela Vyas. Yeah. Professionally, she is Senior Consultant, Cocoon Hospital, Jaipur. She is Senior Consultant, Aesthetic and Cosmetic Gynecology at Vyas Clinic, Jaipur. And she is ex-Senior Professor at Unit Head at IVF Consultant, Member of Research Review Board, SMS Medical College, Jaipur, which is well known. Now, organization position, she has been Vice President, Foxy, 2018, President, Naki, Rajasthan, President, Jaipur OB-GYN Society, and Secretary, Jaipur OB-GYN Society. She has number of publications to her credit, 25. Special awards and recognition, she's got lot. Excellence Award by Jaipur Medical Association, 2009, and a field of special interest. Again, it is high-risk obstetrics, infertility, endoscopy, aesthetic and cosmetic gynecology, which is also coming up very fast. Welcome, Dr. Leela Vyas. Thank you so much for being here as chairperson.
And next also?
Yes. Next. Can you share, Sana? Yes.
Yes.
Now I'd like to welcome Dr. Professor Mala Srivastava. She is Senior Consultant and Professor with Gynec Endoscopy and Robotic Surgery at Gangaram Hospital. She is President 2020-21 of AOGD, Zonal Chairperson ISOPAB, Executive Member of AOGD 2019-20, IMS Delhi Chapter, NAKI, ICSP, and so many from Delhi. She's everywhere there. Secretary, ISOPAB Delhi Chapter, National Corresponding Editor of Journal of Obstetrics and Gynae of India from 2017 to 19, Chairperson of ISOPAB Quiz Committee 2018 to 2020, Ex-President, Ex-Secretary of Alumni Association of Gangaram, Chairperson of the Community Health Committee, and Chairperson of Cervical Cancer Awareness and Prevention Committee of AOGD from 2016 to 19. She has been Joint Secretary of IMS 2016 to 19. And she's Governing Council of ISCCP 2018 to 20, Endoscopy Committees, Safe Motherhood Committees, Oncology Committee, and Endoscopy Committee. So no committees left, I hope. Joint Secretary of Alumni Association of Gangaram, Naki Delhi branch, and Delhi branch from 2004 to 2006. So Mala Srivastava is a very prolific speaker, but as a chairperson, I would like to invite her today. Welcome, ma'am. Over to Sir, Pratik sir.
Dr. Apurva.
Requesting the chairpersons to please introduce Dr. Apurva formally.
I think, sir,
it's a pleasure to introduce the speaker of the day, Dr. Apurva. May I have his detailed CV? It's a pleasure for us to introduce him.
Thank you so much for the kind words. Ma'am, I think already introduction was there and we are running with the permission from Archana ma'am. Can we directly come to the
Yes,
slide?
yes, yes, yes.
Yes,
Okay.
yes, yes.
Thank you so much, ma'am. Thank you, Mala ma'am.
You're the young, vibrant, active member of Foxy. We, I'm sure we'll find you in many, many more activities in the future.
Thank you so much, ma'am. Thank you so much, ma'am. With the permission from you and Ila ma'am, can I start the today's talk? Yeah. So the topic for today's discussion is the recurrent pregnancy loss. So traditionally we defined as 3 or more conventional consecutive miscarriage which occurred before 20 weeks is known as the recurrent abortion. But few authorities says that it is 2 or more miscarriages, then we call it as a recurrent pregnancy loss. So what are the risk factor? Risk factor, we all know it is the maternal age, previous miscarriage is very important, the obesity, and certainly the environmental factor like smoking, caffeine, and alcohol consumption. Now, quickly, the cause of the recurrent pregnancy loss, mostly it is the unexplained. It is comprised of 40 to 50%. The another are the genetic factor, anatomical factor, autoimmune, infection, and endocrinal factors. Now, quickly to the genetical factor. Genetical factor, when we suspect there is a genetical factor, if the maternal age is very advanced, if there is a history of malformation and mental tradition in the family, if there is an embryonic pregnancy, and there is a repetitive first trimester pregnancy loss. Now, what is the management? Genetic counseling is the most important. Second, if it is the assisted reproductive technology, we should include the pre-implantation genetic diagnosis. If it is very severe, then we should use either the donor oocyte or donor sperm, depending upon the affected partners. Now, the anatomical factor is either congenital or acquired. It comprises of 6 to 7% of the recurrent pregnancy loss. Congenital causes, we all know it is septate uterus, uniconverted uterus, didelphius, biconverted uterus. Acquired one is most common is the uterine leiomyomas, Asherman syndrome, and incompetent cervix. Now, how will you diagnose? We diagnosed by sonohistography or by histosalpingography, but the gold standard is the hysteroscopy, which is diagnostic always as therapeutic in case of intrauterine lesions. The others are, we have very good ultrasounds, the 3D and 4D ultrasounds are available nowadays. We can also do an MRI, basically to differentiate between the septate uterus from the biconverted uterus. Now, what is the treatment of the euconverted uterus? Usually no surgical procedure is required, but if it is there and repeated ultrasound shows there is a cervical incompetency, then cervical cerclage can be prescribed to the patient. Septate uterus, it is the most common developmental anomaly in the uterus. It comprises about 65% of the miscarriages among the defect in uterus. Now, what is the treatment of that? It is actually septate uterus not always associated with the poor pregnancy outcome, but if it is at all associated with the repeated pregnancy loss, then hysteroscopy, septoplasty is the treatment of choice. Coming to uterus didelphius, the removal of an obstetric longitudinal vaginal septum is required, but the recommended technique is just unify both the fundus and leave the two cervix intact. If it is a biconverted uterus, then surgically is generally considered unnecessary. If at all it is the cause of recurrent pregnancy loss, then Stresemann abdominal metroplasty is the treatment of choice. Coming to the uterine leiomyomas, it is the FIGO classification group 0 to 3, and in group 4 are the category which actually causes the recurrent pregnancy loss. So if it is present in our evolution, we have to remove that. But if it is in the intramural and it is the subserosal, there is a large fibroids and it distorted the cavity, then it's also the surgery is required. The surgical treatment is definitely the hysteroscopic or abdominal myomectomy. Now, next is the Asherman syndrome, or also known as amenorrhea traumatica. The treatment is diagnosis. We can just have suspicious of this depend upon the history. And the patient also gives the complaining of scanty flow or no withdrawal bleeding after treatment with the estrogen and progesterone. The treatment is the hysteroscopy. It is diagnostic as well as the therapeutic. But one thing we should always remember, after doing adhesionolysis, there is a very high chance of recurrent adhesion band formation. So we have to insert either intrauterine banding catheter for 7 to 10 days or intrauterine devices, IUCTs in situ. But we have also give the treatment with the higher antibiotic, non-steroidal anti-inflammatory drugs, as well as exogenous estrogen for approximately 4 weeks after the surgery, so that there is a rapid re-epithelialization of the endometrium and there is a chance of recurrence is low. Coming to the cervical insufficiency, now how will you differentiate between the cervical insufficiency or preterm labor pain? In preterm labor pain, there is a uterine contraction is present, but in case of cervical insufficiency, there is an absence of the uterine contraction. So what are the cause? The Mullerian congenital or the Mullerian tubal defect, or we have the abnormal collagen tissues defects like Marfan syndrome, or diethylstilbestrol exposure in utero. Now the acquired one is forceful mechanical dilatation, cervical laceration, or cervical cone or leap procedure. Diagnosis either during acute presentation, or there is a by the history, or we have the ultrasound diagnosis. So during the interconceptional period, how will you diagnose? We can just simply a OPD procedure. We can pass a 8-number Hager's dilator beyond internal os. If it is, there is a no resistance, there is a no pain, and there is an absent of internal os snap, then it is the incompetent cervix. We can also have cervicography. We can also use the catheter number 6 passed in the uterine cavity. And if it is a pull out easily after giving 2 cc of normal sign, that means it is the cervical incompetency. Next is the Sirodkar test. It is the same. We have to pass the uterine sound without resistance or pain is the diagnostic of incompetent cervix. Now the treatment, we all know Sirodkar, McDonald's operation, abdomen ceilings, and the rare are spinal floor operation or womb operations. Coming to the intracranial factor, we also have the thyroid disease, not very uncommon nowadays, the diabetes, polycystic ovarian disease, and luteal phase defect. I will talk about in very short the luteal phase defect. Luteal phase defect, what actually it is? It is the lifespan of the corpus luteum is shortened, and there is an inadequate progesterone release by the corpus luteum. So the maintenance of the pregnancy during the first 7 to 9 weeks is not maintained, and it causes the abortions. Now the gold standard of diagnosis of luteal phase defect in the endometrial biopsy. But since it is invasive one, so it is not preferred, and by taking a simple history, that is by taking the abnormal shortening of the luteal phase, we can calculate by the interval from detection of the mid-cycle LH surge to the onset of the menses. If it is less than 13, then there is a chance of the luteal phase defect. Now, what is the treatment? Actually, we all are giving the progesterone, but there is a insufficient evidence to evaluate that the pregnancy is prevent a miscarriage. Now, the infection, there is a no infectious agent
बोले हम लोग का एक कम से कम
has been proven to cause the recurrent pregnancy loss, but certainly it is present with the recurrent pregnancy losses. Immunological factor, not going detail. We have most common 2 autoimmune diseases, that is SLE. Risk factor is up to 20% of the chance of the pregnancy loss. And secondly is the APLA, antiphospholipid syndrome. The 5% of the recurrent pregnancy loss is due to the APLA syndrome. In a very short, how will it diagnose? We have a Sydney revised Sapporo criteria 2006. We define it as a APLA syndrome if there is a 1 clinical and 1 laboratory criteria is present. The clinical is the history of the vascular thrombosis is present, and there is a pregnant morbidity. The laboratory criteria is the presence of anti-cardiolipin antibodies, lupus anticoagulant, and anti-beta-2 glycoprotein IgG, both IgM. If the one clinical and one laboratory investigations is present, we call it as a Apla syndrome. Now, when to start the treatment? Aspirin should be started when pregnancy is been attempted or documented. Heparin should be started as soon as cardiac activity is documented on TVS. So the dose we all know, it is an unfractionated heparin, 5,000 to 10,000 international unit subcutaneously twice a day. Or nowadays, which it's much better and safer, is the low molecular weight heparin plus low dose aspirin. Next is the inherited thrombophilia. We are not going to detail into that, but when the other factors are not found, we should consider these as the cause of the recurrent pregnancy loss. Treatment is almost the same. It is the low dose aspirin plus subcutaneous in unfractionated heparin or low molecular weight heparin. Now, how will you evaluate? Yes, history is very important. What is the time, the pattern, the history of any chronic illness is there, any exposure of the toxin or drug, or there is a obstetrical, any other obstetrical infection. Now, family history is also important, and the previous diagnostic tests and treatment is also important. Now, what to evaluate? Yes, physical examination and pelvic examination is very important. Now, other specific investigation I already mentioned according to the causative factor which we are suggesting from the history. We should do those investigations like karyotyping in case of genetic chromosome and accordingly. So management with the idiopathic recurrent abortion, yes, the management of the recurrent.
Only 1 minute is left.
Yes, ma'am. The management is just to treat the underlying cause. In case of idiopathic recurrent abortion, the counseling is very important, and we should counsel the patient that in a 70% case you will get successful pregnancy if you have the conservative miscarriage. So counseling is very important. Folic acid should be continued before conception period. Correct the nutritional deficiency. Empirical antibiotics, luteal support, though not recommended but can be given. And the post-conception with the reassurance, tender love care, prophylactic aspirin, cervical cerclage, if it is documented, endocardiolipin antibodies, if it is present, the low molecular dose heparin, steroid for the lung maturity, and close monitoring near the term. Now, that's all from my side. I think
Yes.
very quickly I have finished it.
There's no time left for the panel actually.
Yes,
Thank you, Dr.
Okay.
Apurva.
Thank you so much, and hand over to the chairperson, ma'am.
Thank you, Dr. Apurva. That was a really good deliberation from your side. And I'm sure there is no time for the questions. Dr. Archana?
Yes, ma'am.
We have to move on to the next panel.
We will take from the chat box as such, because we are not taking already so much late. We are.
So
Dr. Leela Vyas, you want to say something, Madam Leela Vyas? Dr. Leela Vyas is here.
I think we can move on to the panel discussion.
Yeah, okay, let's start.
Salna, can I have the CVs, please, so I can introduce everybody formally? Archana ma'am, do you want to do the honors? Should I go ahead?
Yeah, I will just say.
Okay.
Dr. Mandakini, please. Dr. Mandakini Pradhan. She is a professor and head of the Department of Maternal and Reproductive Health, SGPGI MS Lucknow, and she is chairperson of Genetics and Fetal Medicine Committee, FOXY. She has innumerable publications and got Health Icon Award of 2018 and Woman Achiever Award of 2018 and ETV International Women Day Award. And Ministry of Information, Ministry of Information and Technology Award, हम किसी से कम नहीं, and Governor Meritorious Award, and she's really a very PhD kind of a person and a fetal medicine expert, and she is doing all that which I think nobody in the India is doing. Okay, over to Dr. Mandakini Pradhan, and please introduce all your panelists also.
Yeah. I must share my screen first. Thank you. My slides are visible. Hello.
Yes, ma'am. Your slides are visible.
Yes. Thank you, Dr. Archana, for all those PhD things. I'm not a PhD. I'm just a simple person, and we are here with this all these audiences. And thank you so much. And almost this RH negative is covered. So I will be conducting next. Can I take 20 minutes?
Oh, no, you take, don't worry, we had time.
Okay.
We, unless and until they say the time is, we are going to close the webinar.
Yeah, so I hope that this panelist is ready for everything, and we will have a good discussion after that discussion by Dr. Vatsala and Dr. Archana already. And the topic is almost very well covered. So I have got Dr. Indu, Dr. Sajia, Dr. Neha, Dr. Ansu, Dr. Pratibha and Dr. Nivedita. They are from north to east, and I don't think anybody is from south. Anyway, so in this era, all of us wants to become negative. Earlier it used to be positive, but now it is negative. Everybody wants a report of negative. But what about a blood group? Blood group, we think we should be positive. So positive or negative, and today we'll be discussing something about RH negative. And so is it good to have a RH negative pregnant woman? What is good about RH negative? Dr. Neha, can you enumerate?
Good morning, good evening, everyone. Thank you, Dr. Archana ma'am, for having me on the panel. There is RH negative pregnancies were initially having a lot of neonatal mortality and intrauterine deaths also. But now with the advent of new technologies, with anti-immunoglobulin availability, there has been a very positive effect, as in a lot of decrease in the isoimmunization, and as it has been already discussed in previous lectures, from 16% to with postpartum prophylaxis we have reduced to 2%, and now further with routine antenatal anti-D prophylaxis 0.2% isoimmunization levels are seen.
Yes.
Now, one distinct advantage with RH negative patients may sometimes have is having less toxoplasmosis also. As in the effect of toxoplasmosis in an RH negative patient if she is pregnant is going to be lesser. This is something, another interesting fact about RH negative patients.
That excellent. Probably this fact I am not aware about it, and I have never come across. So you I got some food for thought. But then this is a condition which is preventable, and if at all it is not prevented by somebody, some mishaps, anything, whatever cause, those causes Dr. Vatsala very well demonstrated, it can be treatable. So as high as 95%, 90%. In fact, today I was busy in doing one transfusion of a mirror syndrome patient. So mother has developed mirror syndrome because of fetal hydropy, absolute hydropy. So let's come on to case 1. Dr. Nivedita, this is a patient of a primigravida presented to you at 12 weeks of gestation. Her blood group is O negative and her husband blood group is O positive. When do you do an ICT in this patient? She has presented to you at 12 weeks. This is a era of COVID. So when to do her ICT?
Excuse me, madam, your slide is not visible.
Not visible?
No, we are not able to see.
This?
No, ma'am, it is not visible.
Okay.
No, madam.
Is it visible now?
Yes. Yes.
Okay, so should I go on to full screen?
Yeah, yes, madam.
Yeah, great. So the previous was, it is prevention is available and treatment is available. So now we have come on to the first case, that is she's primary, 12 weeks, O negative, husband O positive. When to do her ICT? And this is COVID era. Dr. Nivedita?
Nivedita, unmute yourself. Dr. Nivedita, unmute yourself.
Sorry.
it is preferable to do an ICT initially when she comes, and then if it is negative, repeat it at 24 weeks.
So you will do it, Dr. Sajia, her ICT is negative. Like you have done it at 12 weeks. That's her first visit to your clinic. Now her report is negative. So can you tell me at what interval ICT to be repeated? Dr. Nivedita says it is to be 28 weeks.
ICT is to be done in a primary gravida at her first visit, and then if she is negative, we will repeat it between 24 to 28 weeks. And if it is again negative, then we can give a shot of anti-D immunoglobulin. And
great. So, do you think that these primary gravida? Just a minute. Do you think that these primary gravida are always primary gravida?
No. Sometimes
Yes.
they may have a hidden history of some miscarriages. Sometimes there may be a history of transfusion somewhere,
Yes.
even a platelet transfusion.
Yes,
And
great.
sometimes there may
So-
even be a grandmother syndrome. So a grandmother theory. So either way, they can be immunized.
Yes. So what is this thing is that if the patient can come to the hospital, if it is otherwise a normal duration, and you can do repeat every 4 weekly. If not, then you do it definitely at 28 weeks. So everybody agrees for that. First visit and then 28 weeks.
28.
If it is negative. ICT continue to be negative till 28 weeks. What would you do? Dr. Anshu? Dr. Anshu, unmute yourself and then answer.
Till 28 weeks if the negative.
Unmute.
I'm audible?
No,
Yes,
your
yes.
voice is coming from very far.
I'm audible now?
Yes, tell me, I will repeat.
Even till 28 weeks the ICT is negative, I would like to give the prophylactic dose of the anti-D, because even the small amount of feto-maternal hemorrhage which can happen in the third trimester and cause the sensitization of the woman can be prevented by giving this dose. And the
Okay.
second thing,
So we give injection anti-D, antenatal prophylaxis. Everybody agrees now that at 28 weeks we give antenatal prophylaxis to all women and at a dose of 300 micrograms.
And this will not only prevent the sensitization, it will prevent up to the term. It will give at 28 weeks. For the 12 weeks, it can be covered.
So can Dr. Pratibha, can you tell me how useful it will be? How many percentage it will decrease the isoimmunization?
Yeah. It is seen that about 1 to 2% of Rh negative mother have a silent bleed, so while occurring during the pregnancy, and when it is mainly when it moves towards the in the third trimester. So it will cause sensitization in the women in that period. And so only postpartum prophylaxis is not enough, because this may cause serious consequences in the fetus when it is delivered, like hemolytic disease of newborn.
Great.
And this antenatal anti-D prophylaxis has been advised, and now our all guidelines are saying that we must give this antenatal anti-D at 28 weeks, because it can affect its effect lasts for about 12 weeks. So it will be preventing from 20 to 40 weeks.
So it is now clear that antenatal prophylaxis is to be given at 28 weeks. How many antenatal prophylaxis and what doses? Dr. Indu?
Yeah, good evening, everyone. Am I audible?
Yes, yes. Very well.
So the single dose is preferable at 28 to 32 weeks of gestation. That is 300 microgram. Is to be given intramuscularly. There are very RCTs which say that you can give double dose also, but it is single dose is equally good as compared to double dose.
Yes, great. So there should not be any confusion. There was a time when we also used to give at 28 weeks and 34 weeks. Now the recommendation is single dose 28 weeks, and that is not to be repeated. So at a dose of 300 microgram, and that is American College of Obs Gynae also do. And Dr. Neha, would you like to do an ICT after giving this antenatal prophylaxis? The woman has received antenatal prophylaxis. Do
There
you
is,
advise an ICT?
There is no role of doing a repeat ICT after this antenatal prophylaxis because
If we move fast, then probably we can go up to the 5th case. So that's why I'm little faster. So ICT should not be done once you give antenatal prophylaxis because it is expected to be positive.
It is going to be weekly
Dr. Nivedita, when do you deliver this woman? Primi gravida, 28 weeks.
We'll take her up to term unless she has any other obstetric complications.
Great. So we take her up to term, but then we will not advise to go post-term.
We will not post data.
Even not 40. So we deliver her at 40 weeks. Do you deliver at any center or a center which is equipped with neonatal facility? No complication, no GDL.
Since she's uncomplicated, she can be delivered in a center, in any center, but the center should at least have a neonatal backup so that the neonatologist can examine the baby afterwards for any complications which arise.
What?
Like
there should be facility for phototherapy and
why phototherapy?
No. She can deliver in any center, but there should be a backup of a neonatologist, even if it is on call. Even if she is on
you
call.
are delivering this patient, and at the delivery room, what cord blood investigation you would like to?
Just after the delivery, we should take the capsules for the fetal hemoglobin, RS, serum bilirubin, and the direct test is to be done.
First is
blood group, ABO, RH, and the direct food test is also marked, the hemoglobin, the serum bilirubin, because we need to follow up after some time if the baby is developing hyperbilirubinemia, or we may need exchange transfusion. So at birth, we should also test the serum bilirubin along with the blood group and DCT and hemoglobin. And hematocrit also we can check.
Hemoglobin multiplied by 3 becomes hematocrit. So hematocrit you may not like either hematocrit or hemoglobin you can send, but you must send for blood group. That's a must. Why do you check for blood group? This baby's blood group is A positive and DCT negative. So Dr. Anshu, what do you give?
300 microgram. If the baby is positive, 300 microgram IM intramuscular anti-D should be given, and it will be preferably within 72 hours. But if some reason it is delayed, we can even give up to 10 days, or some literature say 28 days. So that is the thing.
And which site would you like to mention the site of injection in this
intramuscular? Intramuscular.
And deltoid.
Preferably deltoid.
Dr. Archana very well enumerated that. Yeah. So it has to be deltoid and not buttock.
Deltoid.
So if you give in the buttock, then all anti-D will be in that fat. So it will not be effective. So please friend, those who have joined at least must give the instruction to give this injection in the deltoid region, because many of the isoimmunization is because of this giving injection in the gluteal region. So postpartum prophylaxis 300 microgram, preferably as early as possible and preferably within 72 hours. And you always need to do it in the deltoid. And in patients with bleeding disorders, you can give subcutaneous or intravenous, but the preparation needs to be checked if it can be given intravenous, and consent should be obtained and recorded in the case note in such a case. So what message did we get? Antenatal prophylaxis at 28 weeks, postnatal prophylaxis after delivery if the baby's blood group is positive and DCT negative, and antenatal anti-D, Dr. Archana very well told us that it covers all the epitopes of antigen. So hence polyclonal is better than monoclonal, and for your information, the availability of polyclonal is very less. So practically we end up in giving monoclonal, which may not be very, very effective, and deltoid. So this is the same thing that a patient Rh negative pregnant woman, husband blood group, it is positive. These days I don't rely on husband blood group and I must write it is partner's blood group. And ICT is negative on first visit. If facility available, repeat it every 4 weekly. Otherwise at 28 weeks, ICT remains negative. You give antenatal prophylaxis delivery at term, postnatal prophylaxis. So that's all about giving this thing. What are the indication of giving antenatal prophylaxis? What all other condition you give antenatal prophylaxis? Dr. Indu?
Antenatal prophylaxis, other conditions, like what I was thinking is that NTD prophylaxis in the patients who has got early, any kind of pregnancy she has got, early pregnancy, ectopic pregnancy, missed abortion, threatened abortion. Very important is threatened abortions. Sometimes patient has a bleed and we tend to miss it. Then when, if we are having any procedure is being done like CVS, amniocentesis, ectopic pregnancy, then any patient who has got
pregnancy.
This IUD, we should be giving antenatal prophylaxis, manual removal of placenta, and any other procedure is being done, we should give antenatal.
So we must be aware and aware about patient blood group and aware about all these conditions so that we can advise a dose of antenatal prophylaxis other than the at 28 weeks.
Yeah,
in
and
fact,
the dosage,
today I did an amniocentesis and the mother's blood group was Rh negative. And we gave antenatal anti-D and and pasted that anti-D's sleep on her card so that she can keep it for anyone to see that this was given. So let's come on to the second case. Here is a lady who has at 18 weeks her ICT is positive and antibody titer is 1:2. So Dr. Neha, what other history you would like to know in this patient?
This is suggestive of a already sensitized pregnancy, and we would like to ask what were the delivery events, her obstetric history, whether she was ICU-immunized and it was known, and whether any intrauterine transfusion was done, whether the baby had jaundice, there was intrauterine.
Dr. Neha, do you think that at 1:2?
No,
it's very less.
No,
so
1:4 is the minimum to say sensitization.
If she has received any anti-D in this pregnancy, would also be the cause, because 18 weeks maybe first trimester.
You can stop here. So first is history of receiving anti-D. So my next question is, how long, if a woman receives anti-D, then how long this anti-D can remain in her blood, and we will interpret it, the positivity or ICT being positive is because of her injection anti-D received in her previous pregnancy.
So it usually, the mean life of this immunoglobulin is 24 days, 16 to 24 days. It stays usually for 3 weeks, but 180 days, till 180 days also it has been seen. So we have to interpret our results accordingly.
Okay.
And since the titers are very low, so it is because of this injection.
So cause of low and titer in anti-D can be previous injection of anti-D and recent isoimmunization. Okay. It can be recent isoimmunization. Coming on to how long this anti-D remains in the blood we were talking about. Dr. Sajia, can you point out
the half-life of the anti-D RH immunoglobulin can be detected up to 1 year, and the patient who are receiving passive isoimmunization, the titer is usually up to 1:4.
So we must remember that the titer will not go beyond 1:4, and if the previous pregnancy ended 1 year back, so still it can remain 1:4. So if you are getting a titer of 1:2 or 1:4, and a woman who has delivered within 1 year, please do not worry. This is because of her passive immunization or receiving anti-D. Great. So how frequently you monitor this patient? Yes, for first 18 weeks scan.
थोड़ा म्यूट कर लीजिए लोग कौन भी जो है.
Yeah, people are talking and we are not able to listen the panel properly.
I would like to meet this patient monthly, and I just keep watch on the titer. If the titer is increasing, then we have to be little
So
vigorous.
how frequently? This is non-COVID time.
It's monthly.
Patient can come whenever you call them.
Ideally, it's monthly, ma'am.
6 monthly?
No,
monthly.
every 4 weeks.
Every 4 weeks. In a patient who was Rh negative, non-ICU immunized, ICT was negative, we did it at 4 weekly. A patient whose this thing is 1:2 or less than critical, again we follow that patient 4 weekly.
You need not.
Little, yeah, yes.
Yeah.
So little more,
Every
like
2 to 3 weeks, and if the titer is rising, definitely would like to see the how it is rising.
Yes.
And if it is critically going like 1:16 kind of titer, then definitely we'll go for the vigorous
so
one.
that is great. So if a patient whose titer is less than critical, so then we do it 2 to 3 weekly. And then if it is going up or remains that, so we need to see it. So if the titer is, Dr. Pratibha, if the titer is less than critical titer, and it continues to be 1:2 throughout the pregnancy, maximum it went up to 1:4. So when do you want to deliver this patient?
Ideally, it should be delivered at, and the facilities for neonatal exchange transfusion should be there at that place. That is the thing.
So we do not allow this pregnancy. It is less than critical, but
it
this
should
is
not
a patient
be post-dated,
who will be
post-station
delivered at a center which has got an exchange facility. So this is a patient not to be left in a center where there is no exchange facility. Great. So what we dealt with is a Rh negative pregnant woman, husband's blood group is positive, mother ICT is less than critical. So we have followed her up 2 to 3 weekly, and ICT has remained less than critical. So we are delivering at 38 weeks and we are ready for an exchange transfusion. Baby may or may not require exchange transfusion. So now coming on to our third case, 32-year-old, third pregnancy, 1 loss, 26 weeks with previous 2 LACs, previous fetal death at 36 weeks, Rh negative, received injection anti-D in both pregnancy. She had an autopsy of the previous child which says that fetal ascites and cause of death could not be determined. This is a true story. It is not this thing that I have taken out. This is a true story. So Dr. Indu, what investigation would you like to do?
Indirect Coombs test.
First is indirect Coombs test. Along with that, anything else?
Titers.
No, let's come out of Rh negative panel. So a patient who has previous third gravida, previous IUD, intrauterine fetal death at 36 weeks. We definitely would like to do it.
Complete BOH panel we'd like to do.
Yeah, or blood sugar, minimum blood sugar we must do it, and it has to be a GTT.
Yeah.
So IUD at 36 weeks, we would like to see for APLA also.
Yeah.
And that is a separate issue. So you have done an ICT and an antibody titer. What do you expect? If ICT is positive, what do you expect out of this history or with this scenario?
At least the titer should be more than critical. That means more than 1:16. It can be any high. It can be
So
any.
it is expected to be high. And what was her report? So ICT was positive and antibody titer were more than critical. So at what gestational age you will start monitoring such a patient? She has come to us at 26 weeks, was referred to me. But if such a history is there, when you start monitoring, next I will go how we will monitor. But let's first see when
26 weeks
with 8 weeks, 3 weeks, what weeks?
In the current case, the patient is already at 26 weeks. We must start monitoring her right away because the critical titers are, we have checked the ICT titers and they're critically raised, more than 1:16. So we would start doing the ultrasound Doppler MCA PSV levels, and we will follow it every.
He has repeated to you at 10 weeks.
If she has presented to us at 10 weeks, then we would like to start early, maybe at 16 or 18 weeks. And
is there anything which guides you?
Yes, we should go for checking the zygosity of the husband.
Is it available in India?
Possible, it's usually
available
not
in India?
It
So
is
here in this panel, whatever we are discussing practical thing. If the test is not available in India, nobody is doing. I did one thesis on it. So if it is not available, there is one center who may or may not be doing it. So practically, say for
practically, ma'am, it was just discussed that Dr. Vatsala, like she had even presented that IVIG is an option, but obviously these are things which are
what we are saying
at very early gestation. If
Just
there
a
is,
minute. What we are saying is a patient who had a previous IUD at 36 weeks.
It is going to start earlier
and
more severe.
What early is 10 weeks before the previous affection. So if she has had a pregnancy which was lost at 36 weeks, so 36 minus 10, so from 26 weeks, we will be careful and monitoring this patient. If a patient had a loss at 30 weeks, so we start monitoring our subsequent pregnancy at 20 weeks. So that we should. And what do you mean by previous affection?
Previous affection could be hydrops, fetalis, fetal death, blood transfusion, intrauterine transfusion, fetal post-delivery fetal transfusion, connectors, and its sequelae.
Yes, very good. So everything are put under one umbrella of previous affection. So 10 weeks minus previous affection will be the gestational age. So at 26 weeks, refer to our center as recurrent fetal ascites. MCA-PSP was very high. Fetal transfusion was done in this patient 5 times and the patient delivered previous to cesarean. So delivered by cesarean at 36 weeks, baby is doing well. So can a woman get isoimmunized even after receiving anti-D in all her previous pregnancy? Dr.
Yes, ma'am.
Nivedita?
Yes, ma'am.
Yes. Yes.
Yes, one is that they say that there is a 0.3% chance of getting immunized, isoimmunized, even if she gets anti-D. It could be some amnestic reaction. Sometimes the patient might even omit a history of any missed abortions, or she could have just, like, she could have aborted and not known about it and hidden a history from you. Any history of transfusions, platelet transfusion, any history of such platelet transfusions especially, even that can give a history of isoimmunization, which we will not know. Then if the drug is not given at the right site, in the right dose, and you have underestimated the pituitary hemorrhage.
Great. So you have covered everything, except only one thing is cold chain has to be maintained for anti-D also. So in periphery, there are sometimes the cold chain is not maintained, and that's the reason why this anti-D is not effective. So we now know that what could be the cause of isoimmunization even if she has received anti-D. So even with history of anti-D also, still we continue our monitoring. How do you monitor this isoimmunized pregnancy? Dr. Sajia?
Yes, ma'am. If a
You have
patient
already covered. Yes.
in an isoimmunized pregnancy, we should do regular antibody titers every monthly up to 28 weeks, and then
in an isoimmunized pregnancy.
Yes, in an isoimmunized pregnancy, we should do a regular antibody titers, and we should
Dr. Sajia, here is a patient who has got antibody that is more than critical. That means he has lot of antibody in her body.
The antibody titer is more than the critical level. We should do the fetal surveillance, and the best way to do fetal surveillance is by the Doppler MCA-PSV MCA.
Right.
And the value of this should be more than 1.5 MOM, or depending upon the gestational age.
So,
and
history is suggestive. Like this patient, she has a suggestive history of fetal ascites. Somebody has detected fetal ascites and had an IUD at 36 weeks. I don't rely much on my lab. Like, experience of lab is not always that equal. So you can do a MCA-PSB if you are good at doing it, and monitoring can be done 10 weeks before the previous affection, and it can detect early detection of fetal anemia. So how do we monitor a patient who is isoimmunized is by monitoring MCA-PSB. So coming on to the next case, 22-year-old primary ICT positive antibody.
डॉक्टर मंदाकिनी मैडम, आप अभी डॉक्टर लीला व्यास इज ऑल्सो हियर एंड आप इस केस के बाद से प्लीज कॉल हर ऑल्सो. आई वुड लाइक टू हैव सम वर्ड्स फ्रॉम हर बिफोर वी आर क्लोजिंग बिकॉज इट इज ऑलरेडी गोइंग वेरी लेट. Okay.
So can we stop here?
Just ask na question फटाफट ये वाला last वाला कर लीजिए.
So ICT and then ICT is positive, antibody titer is more. So what we do is we do MCA-PSB, and then once there is hydrops or MCA-PSB is more than this thing, how do we, simple way of calculating MCA-PSB, Dr. Indu, can you enumerate? Simple way.
Yeah, simple. Just do the ultrasound. Fetal head should be in the transverse position. Put color, see circum of Willis, identify the MCA, and then put power Doppler and see the 3 waves at least without any fetal breathing and fetal body movements.
Yes.
And then it has to be interpreted by MOM, multiple of medians, and that is specific for every gestational age.
Yes.
So it has to be more than 1.5.
Yes, more than, I do not have a computer, I do not have an internet. So
then
how
a
do I do?
Simple way of doing double the period of gestation.
Yes, great. So I appreciate this. So if you double the gestational age, like she is 26 weeks, you double it 52. If your middle cerebral artery peak systolic velocity is more than 52, then that is more than 1.5 mmol. This indicates fetal anemia, and this baby needs fetal transfusion before the baby becomes hydropic. So that's this thing. So ultrasound feature of fetal hydrops, anybody can take up. It can be placenta, large placenta.
There can be a presence of
pericardial infusion,
polyhydramnios,
or skin edema.
Okay, thickness will be more than 5 millimeters.
This baby received ultrasound showed fetal hydrops. This our last case. She presented as a case of the last case was 8 gravida, and one baby this was alive, and her first daughter is married actually. In fact, this daughter was connecterus and then developmental delay. So she came with this, and then we did. She came with fetal hydrops, received fetal transfusion, spontaneous labor, normal delivery, 36 weeks. Baby received IVIG phototherapy and discharged from hospital. So this was the baby. So what we learn is obstetric history may suggest isoimmunization. ICT is expected to be positive and titer to be more than critical. And in that case, you do not do a ICT, you do a MCA-PSB. If it is more than twice the gestational age, then this is for fetal transfusion and refer the patient. So this is what this thing. All of us now know that prevention is better than cure, and everybody should prevent yourself and remain safe from COVID. And this is another condition where we can prevent it. And what we learned is non-isoimmunized, we must prevent. Isoimmunized, less than critical, we must monitor. Isoimmunized, we more than critical, we must monitor with MCA-PSB so that the fetus will not end up with hydrops. Even if hydrops, do not lose heart. I have transfused with hematocrit of 2, that is hemoglobin less than 1. And this mirror syndrome that I did today, like it's going on, this was less than 2 hematocrit. That means the blood was fully water. And the mother has relieved of her mirror syndrome. So this is a condition which is preventable, but treatment is also available. So let's join hand and do it. And I invite Dr. Lila to
have a question.
We invite Dr. Lila to this thing
to come and say. Dr. Lila, please.
Dr. Lila, please give some comment.
Good evening, everyone. And Dr. Mandakini, congratulations. You have presented all live cases. I know you have a vast experience of these cases. And your 2 students are with me. Savita and Megha, both are here. And last 2 days back, we have one webinar and Savita was with us. So really, we are getting your benefit here also because your students are working with us. So now the time, because after this webinar, everyone must have come to know that there is no death with the Rh negative mothers. Means the baby, we can save the baby, because initially what we in our student life, we learned that Rh negativity is one of the cause for the descending order of pregnancy loss, recurrent pregnancy loss, which is in the descending orders. But now there is no this. We should not take this Rh negative as a cause of recurrent pregnancy loss. And we need help of all our colleagues, those who are practicing this fetal medicine. So this joint work and the fetal Doppler and all, these are the very helpful things. So we should join together and save our mothers and our babies. Thank you. Thank you very much for giving this opportunity.
Yeah, Dr. Leela, what I want, I was really impressed on Jaipur that she arranged with all the fetal medicine expert were the panelists, and so I decided ki with Dr. Mandakini and
Yes,
we will do one.
Dr. Mandakini, I want your help also, because your students are with me, but I also need your association with me.
I'm always there for people. I'm always Dr. Mandakini and their people. Yeah, Dr. Vidya.
Yeah. It was an excellent webinar and I attended all. And I always request Dr. Mandakini to be on my platform and teach my students also, because fetal medicine is upcoming branch and always we are scared to treat at the periphery.
Dr. Vidya Thobi, can we keep, hello?
Hello?
Yes, we can hear you.
You can hear na, pata nahi hai kya hua. Chalo, can we keep on the Teachers' Day or 5th September or 6th September, all the students of Dr. Leela Vyas and Dr. Leela and Mandakini, we can make another Rh negative program.
Sure.
And my students
not
also.
RH. Let's keep it something like something which has clicked you, something very, very interesting, so that everybody will be learning something. That will be probably
that will be there. Yeah, we will do.
Sure.
And Mandakini, I was telling you about that certification course also. Please extend from your genetics and fetal medicine as you are a chairperson. So I want my students also to learn. So that certification course now personally they cannot attend, but you have that in your mind now. So just extend to my students also, because
yes,
that's
a course. I thought that I will through Foxy I will spread everybody, but what happens is probably I'm a little down on the order in Foxy's this thing.
No, don't.
No, you are in a very.
Don't feel like that. You are in the order only. You are in the order.
So we will arrange
I will arrange
this thing course, so that if somebody attends that course, at least can understand what is this genetics.
Yes.
Nothing, not high funda. It is very, and everybody should know it now.
Yeah.
This,
we want to learn basics of genetics and basics of this fetal medicine, where we can interfere at our level. Yeah, that basics at least our students should know as a postgraduate.
Dr. Vidya, the basics they should know, and this will be there for some counseling. If they want to go in this special branch, they can enter their time.
At least pre-conceptional counseling.
It's compulsory.
Yeah, pre-conceptional counseling is also important.
Yes.
So can we arrange, Mandakini madam?
Yes, definitely. No,
I will arrange through my committee.
Definitely, Dr. Vidya Thobi, don't worry. We all together. We will do this.
Yeah,
you just give me an idea.
Ji is there.
एक आइडिया दो डॉक्टर लीला एंड डॉक्टर विद्या थोबी एंड डॉक्टर मंदाकिनी एंड ऑल वी कैन डू एंड आप बस सोच लो क्या होता है.
I have a platform, Leela ji. I have a platform. People can support. That problem is not there. So we need not go beyond that.
I appreciate your desire to learn. That shows that you are a great teacher. A teacher who wants to learn. See, these days the students are not learning. Can you imagine? I asked my student that I will be presenting RH negative. I will be teaching you RH negative, my exam going students. And then there was a blood donation camp on that day. They went for blood donation without informing me. I am waiting in the Google Meet so that I will take a class. So the current generation of student is like this.
It's a true story.
It's a true story.
And all can see how lively Dr. Mandakini has made the panel. Everything so easily understandable and really with interest. मतलब जो एक बार सुनेगा उसको interest आएगा ही आएगा. That is a goodness and
thanks to the panelists. All panelists were good.
Yes.
We really enjoyed. We really
simple things and very nicely told. Yeah.
Thank you.
Mandakini ma'am, I have a query.
Yes.
Taxane has got some
IV,
training, yeah.
what about the role of IV immunoglobulin? How often you are giving it to the patients? Intravenous immunoglobulin.
Forehead hand. This thing is the dose of IV immunoglobulin is 1 milligram per kg body weight. So a 60 kilo woman will need 60 milligram, which will be amounting to 2 lakh rupees.
Yes.
And
Oh
this
my God.
will be required every week. So for all practical purpose, the patients that I have managed since last say 10 years, say around 400, 500, only one patient we could able to arrange this amount of money and could able to arrange this. So then the dose that is given by other centers that I have asked them, that is 5 milligram that comes for pediatric patient, the newborn babies. That dose is very, very less. So I do not know how it works. But to me, if you are giving, you must give properly.
Full dose.
My earliest IUT is at 16 weeks. If I can do a intrauterine transfusion at 16 weeks, so I probably go ahead and do a intrauterine transfusion if the patient is not affording. And most of our patient will not afford in this condition. So it's only I have my experience. Intraperitoneal I have given 4-5, which doesn't work. So to the mother, I have given only one patient.
So about what I wrote in my presentation, timely reference and timely consultation with a fetal medicine expert
Yes.
is a must.
Is a must. And these days you can talk to me over WhatsApp.
No, you are you are have this bond for the 3 years. We will talk day and night to you. चेयरपर्सन तो मेरे पकड़ाई में आएगा ही
ये तो आज एक सिर्फ एक पल्स नापी थी, अभी तो बहुत मुकाम बाकी है.
बाप रे.
Abhi Archana ji, you end this with one शेरो शायरी. That's it.
वो RH नेगेटिव में शेरो शायरी तो चल नहीं रही है. Okay, thank you very much.
Okay, thank you.
वो साना was, अरे डॉक्टर
Thank you so much, ma'am.
Dr. Mandakini, wait, that there was some question. I think Sanna was asking if we have time, or Dr. Mandakini will give, or we should close the
I can, if somebody can mail me, I will send the answer.
Where is the question? I did not find any question in the chat box.
You there with the Sana. Sana, do you have? Are you giving, or we should leave the?
Madam, one more thing. I just want to ask. Since it is public awareness committee and this topic was anticipate and action, so why don't we make it compulsory, have camps about blood groups, so this problem will not arise.
मैं तो चुप रहना भी काम करते हैं ये public awareness पे ये भी
ये हो चुका ओके
ये भी तो चुप करके रहे अभी हम अपना करेंगे ये अपना इसको भी ओपन नहीं करेंगे हम अपना ये will be doing
ब्लड ग्रुप ओके ओके मैम
अगर हमारा आइडिया भी लोगों को लीक हो गया ना तो प्लेसेंटल लीकेज की तरह बैरियर की तरह सब हो जाएगा गड़बड़
ठीक है मैडम
तो आई थिंक सना इज आई थिंक आई डोंट थिंक शी इज पेंडिंग सना आर यू देयर
आई डोंट थिंक शी इज वेयर इज शी
Sana is there.
Sana is there. She has muted.
Okay. So should we say thanks to?
Yeah, I'm very much there.
Hi, Dr. Abha is also there.
Yeah. I was enjoying Dr. Mandakini. We are hearing her so often. And we really enjoy Dr. Mandakini. It was excellent.
Yes, Dr. Mandakini को बुलाने के लिए ही इतना सब मेहनत.
हमारे पटना पर उनकी कृपा रहती है, वो अक्सर आती हैं, है ना डॉक्टर मंदाकिनी?
अरे वो आपने कुछ बात है
क्वेश्चन है.
And Dr. Archana, your theory has been leaked. Your proposal of doing this RH blood grouping campaign has leaked. and once you are preparing to arrange this RH negative session again, please include us also.
Thank you, madam. Thank you, Dr. Maya.
So very practical approach, and I saw this video of intrauterine blood transfusion which is not being done at my place. So I was
majority must have not
inviting.
seen, madam. Majority must have not seen common obstetrician.
But I am
And so
admitting
this is really this RH incompatibility was, it was in my mind, and so I did this, and because it was first, and I am planning to do with many, and Dr. Abharani Sinha madam and or Dr. Mandakini, they will definitely, Dr. Leela Vaz, they will definitely help us. और इसको हम लोग हर society में, I think we should do in.
Very, very informative, that practical approach of the presentation, in which she presented this videography of
मैडम वो
transfusion.
सब फीटल मेडिसिन एक्सपर्ट है ना कुछ तो अच्छा बताएंगे ना वो
अभी आपने ठीक ही प्लान किया था ना कि हम तो one of the student, I am the lifelong student of every new thing.
Ma'am, that is the best person. Learning is the best thing.
But very slow process of learning.
ये मैडम हम लोग ये एज में अब यही होगा ना, एवरीबडी इज लाफिंग, अर्चना तू अब क्या कर रही है इस टाइम पे, अभी तुम ना इतना मत पढ़ाई में घुस रही है, सब कुछ है, बट लॉकडाउन का आई एम थिंकिंग दिस इज द बेस्ट थिंग, और व्हाई नॉट आई हैव आल्सो स्टार्टेड, आई एम जस्ट डूइंग इन माय नर्सरी क्लास एक्चुअली, एंड ऑल द प्रोफेसर्स
whether I am doing practically or not seeing the patient, still I want to know everything, whatever is possible. And I repent whether I should have born later on.